Is this on? Okay, perfect. I am so excited to welcome you here to Boston today. It fills my heart to see so many of you here, to see both people in person and virtually. We have quite a few joining us virtually. So excited to have us come together today. Whether this is your first time you've been here or whether you've been with us from the very beginning, as we have a couple of you here, you are part of an incredible community that continues to grow, learn, and move forward together. As I think of our previous conferences and what has emerged from each of those, I am reminded of how they've shaped us into who we are today. We have started as a rare, small but mighty community and have evolved into a respected partner in both scientific and clinical care. What started as just a handful of families has grown into over 2,200 families over 25 countries. It's astonishing to me as I've been getting emails the last little while. I've gotten emails from Russia, from Germany, from Brazil, from the UK, all of them expressing interest in learning more about this rare disease. We've become a global network that is become a strength and a force for good. Through the last year, we have been the recipients of the Chan Zuckerberg Initiative Rare as One grant. This has become very transformative to our organization, and we are growing very, very rapidly. It's given us structure, resource, and most of all, confidence that we know how to help our families and how to work in the scientific community. As we continue to grow, our leadership is growing too, to help us become more sustainable. And so we are proud to announce today that we will be adding to our leadership. I am the executive director, but Nick Sabin will be joining us as our new president. Carly Richards will be joining us as our new vice president. We're excited for their leadership, for their experience, dedication, and fresh energy they will bring into our organization. By bringing them on, we are ensuring that we stay a family-centered at our core as we continue to grow and develop. Today and throughout the conference, you will see the continuation of that evolution. You'll hear stories of science, resilience, and love. You'll see what happens when families and clinicians come together, not just to talk about heterotaxy, but to shape the future of its care. I'd like to turn the time over to both Nick and Carly for a minute, and then we will continue on with our program.
All right, so I'd like to thank all of you for being here today. As I've become a part of Heterotaxy Connection, I've realized the importance and the power that there is of all of us being able to gather together and to share our experiences, our hard times, our good times. So thank you very much for being here. And I'd like to thank Benderson Family Heart Center for helping to sponsor this conference for us and make it possible. I'd like to thank Carly for stepping up to help me in this new role and to help lead Heterotaxy Connection to the forward. And as this conference progresses, I'd like us to remember the mission of the organization to support, educate, and empower. That's the big part of why we do these conferences, to support all of you, to bring education and understanding, and to make you feel empowered and that you're not alone, because you really are not. And I hope all of you feel included, loved, and appreciated. So I like to say, let us face heterotaxy together.
All right, everybody, my name is Carly. So this is a big change for me to be VP, and I want to thank Nisha and Nick for this opportunity. I came to the conference 2 conferences ago. It was my first time, and I saw the bandwidth that HC had, and was able to connect with families and really give the support that is needed. I learned a lot of things at that first conference, and I just felt it in me that being this, having this opportunity to be a part of this organization so I can be a part of that change, and get the doctors here and give the families the materials and the information that they need to go forward. So I'm very excited to work with Nick to get this organization even further from what we've done so far this year, and excited to grow. And so if anybody has any questions or concerns or anything, feel free to come up to any of the board members during the conference, and let's have an awesome weekend together.
So, as Carly said, she was at our last conference, and you might have fair warning. I tend to find people at the conferences that are shining stars that I look at, and I'm like, you can help us make a difference, and I tend to pull them in. So just fair warning. Let's move on to our program. So first up, we are going to have our talk, Heterotaxy as a Whole, Palliative Care. As we've learned throughout the years, I do have a 19-year-old daughter with heterotaxy. And as we have learned throughout the years, we cannot just treat one part. You can't treat one system. It has to be a whole. And we have to give them a quality of life worth fighting for, right? What are we fighting for these kids for if it's not to give them a good quality of life? My daughter was captain of her tennis team at high school. Graduated, all these things I never thought possible, and palliative was a major part in helping us get her to that point. So I'd like to present our speakers. First, we have Dr. Suni Law. He is an attending physician with Pediatric Advanced Care Team at Boston Children's Hospital and an instructor of pediatrics at Harvard Medical School. He is board certified in general pediatrics and hospice and palliative medicine, with a focus on caring for children with medical complexity and integrating palliative approaches into pediatric care. At Boston Children's, he also serves as the pediatric site director for the Harvard Interprofessional Palliative Care Fellowship. We also have Chelsea Hennigan. Chelsea is a pediatric nurse practitioner at Boston Children's Hospital who transitioned into pediatric palliative care in 2018 after years in pediatric oncology. She specializes in supporting children with oncologic, pulmonary, and cardiac conditions, bringing compassionate, family-centered care to children with complex medical needs. We also have Lauren Kramer Finnerty, who is a social worker at the Pediatric Palliative Care at Boston Children's and Dana-Farber Cancer Institute. Thank you.
Good morning, everyone. How's everybody feeling this morning? Good. We're excited. Just give us a moment to set up our AV here and we'll get started.
I think we're missing a connection.
We're missing a connection. Exactly.
Oh, the mics are live. Excellent.
Not flipped yet.
There it goes.
There it is.
There we are. Perfect. So I'm gonna-
round of applause for us. We got our presentation up.
Always the hardest part.
Good morning, everyone. Yeah, thank you for your patience on the technical difficulties. Yeah, we're thrilled to be here. Thank you to Renee for inviting us. We are members of the Pediatric Palliative Care Service at Boston Children's in Dana-Farber, also known as Pediatric Advanced Care Team, or PACT. As was introduced, my name is Suni Liao. I'm one of the physicians with the team.
I'm Chelsea Hennigan. I'm one of the nurse practitioners.
And I'm Lauren. I'm one of the social workers for the team.
Clearly more resourceful than we are. Yes.
Who's the social worker
And that's
on
why
stage?
she's a social worker. Yes. So yeah, we're just thrilled to be able to come and share the next hour with you. And thinking about how palliative care can help support families and patients in facing heterotaxy together. I love the name of the conference. So just some brief objectives. Hopefully in the next hour we'll be able to define and conceptualize what pediatric palliative care is, identify some of the domains of our practice, and describe how we as a team and palliative care teams as a whole can support patients, families, and teams in serious illness communication and decision making. It's a taste of what we do on a day-to-day, and we hope that this can help fill out the picture of how palliative care can serve you as families. So let me start with an illustration or an observation. One is that really just that medical terminology is weird and confusing. And so just follow this conversation with me. And this may be a conversation some of you may have experienced yourself. In this scenario, a family has learned about a prenatal diagnosis of hypoplastic left heart syndrome. And in meeting with a cardiologist, cardiologist might say, well, we can do a single ventricle palliation. Wah, 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 wah. More details about the heart anatomy, heart physiology, what surgery sounds like, blah, 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 all the risk benefits. Basically, the takeaway is that what that means, a single ventricle palliation, that it's a highly intensive, multi-staged open heart surgeries over many months to years, and that these surgical procedures, the word palliation here means that these surgical procedures do not fully repair the heart. It doesn't recreate or reconstruct the heart to become a four-chambered vessel, but instead it reroutes and reattaches the plumbing, if you will, to help make the cardiovascular physiology work better for longer. We now have, this is the standard of practice. This was new like 20 years ago. This is now a very established standard of care, but it is still a very high-risk surgical plan and with lots of potential for serious complications and even death. And then so in thinking about and talking about these complications and death, and in this context, the cardiologist may also say, maybe we don't do surgery, and we can do palliative care. And in this conversation, essentially palliative care here means let's not do surgery, no intervention, and focus on comfort and end-of-life care, recognizing that the time for your baby is short without surgery. So in this one conversation, the words palliation and palliative care are used to describe vastly different treatment pathways. They come from the same Latin root word, and yet they mean very different things. Out of curiosity, has anyone in this room encountered a confusing conversation like this, or had a conversation like this with their doctors? Wow, many hands. I know it's first thing in the morning, but would any of you care to share what that felt like, or what that experience was like in the moment for you?
They haven't had their coffees
I
yet.
know, and it's okay if you don't. Yes.
Yeah.
I mean, for me personally, it was just that I'm trying to understand this, right? And I when they're throwing, I kind of feel like it's that Charlie Brown moment, right? Where it's like, wah, 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 wah. And I'm like, I'm supposed to understand that, and my child's life literally depends on me understanding it. And it's quite daunting, right? You feel like you got thrown into the deep end, and you have to get to a point where you can understand enough to help guide your child. And it's very, very overwhelming.
Well said.
Yeah.
Oh,
Thank you so much for sharing. And I'm not surprised to hear that, right? This is a confusing term. It's a confusing phrase. Different doctors use it in different contexts. Even the medical literature search engines are confused by this. So when I was preparing for this talk, I went to PubMed to look for articles, medical articles about palliative care for patients with heterotaxy. And it gave me dozens and dozens of articles about cardiac palliation surgeries, that first bullet. But only one of them discussed palliative care. And in this article, it made a recommendation that families of patients with heterotaxy syndrome would greatly benefit from the early involvement of pediatric palliative care services. Now wait, what? If palliation means to do surgery and palliative care means not to do surgery, why would patients with heterotaxy benefit from early palliative care? So this is just confusing because we're dealing with three different definitions of practically the same word. And so we want to spend some time unpacking that and helping to think through and define and perhaps redefine what palliative care is and how it can serve patients with heterotaxy. So in 2011, the Center to Advanced Palliative Care, or CAPC, did a public opinion research, basically a Gallup poll, using the term to investigate how the general public thinks about palliative care. And when just thrown out there, what do you think about palliative care? What is your favorability rating? The general public gave about a 35% favorable rating. It's like, look, I don't want to deal with end-of-life care, but I suppose it's important in some cases. So 35% gave a favorable rating. When the term palliative care was associated with a definition and a description of what it does, the favorability quotient, if you will, the favorability skyrocketed up to 92%. Patients and families who heard this definition and understood what it meant felt like it was overwhelmingly a positive service, and many felt that it was important that they themselves or family members would receive this type of service if they were in this situation. So this is the definition that is still on the CAPC website. That palliative care is specialized medical care for people with serious illnesses. Its goals are to provide patients and their families with relief from the symptoms, pain, and stress of a serious illness. It's to improve quality of life for both the patient and the family, and to serve as an extra layer of support by a team of doctors, nurses, and other specialists who work collaboratively with the patient's medical team, and to care for any patient with a serious illness at any age and at any stage of illness to support their goals of treatment. When we think about that definition and think about how to conceptualize it into patient care, this is how we consider it. We consider that pediatric palliative care can work to prevent, identify, and treat different types of suffering in children with serious illnesses, and we work to support their families and the medical teams that care for them. It's appropriate at any stage of the illness and can be provided together with disease-directed therapy. It's not an either or, you do surgery or you don't, but that for all patients in any course of their illness, there's a proactive approach. There's a recognition of the wide impact of the child's illness on the family and their caregivers. And we provide individualized support at multiple levels for all people involved, with the goal of aligning care to the goals of the patient and family. Palliative care is always delivered in an interdisciplinary way. That's why we have physician, nurse practitioner, and social worker here. And we recognize that that suffering comes in different forms, and distress and stress comes in different layers. It's not just medical decision that you're facing, but all these other things that come with it. And that palliative care service can provide a longitudinal or continuity role at different levels or different stages of the illness as things move forward. We recognize that as a patient perhaps gets sicker or things get more complicated or complex, that if it looks like things are trending towards the end of life, we also have the expertise to help support patients and families and medical teams in navigating end-of-life care. And we provide support for bereavement beyond that. At all times in a patient's life, we recognize that there is both a hope for cure, life extension, and miracle, even when things look bleak. And there's always going to be a hope for comfort and meaning, even when things are going well. And so we recognize that families hold that hope, hold worries, hold all these things throughout a patient's life, and we help to support all of that. So with this definition and conceptualization of palliative care in mind, the way palliative care is delivered in our healthcare system today looks different depending on the setting and context. There's one distinction called primary palliative care and subspecialty palliative care. And primary palliative care is defined as care that is provided by non-palliative care specialists. And these include the core competencies of empathy, communication, pain management, shared decision-making, and ethical decision-making that any clinician should have when caring for patients with serious illness. Think of this as palliative care provided by your cardiology team or your complex care team or your ICU team during the course of everyday treatment. As the medical condition becomes more complex, sometimes subspecialty palliative care is consulted to help support the family and the team. Subspecialty palliative care, as I said, is always provided by an interprofessional team, and that seeks to provide a whole person, whole family approach to care. Subspecialty palliative care teams are often based at hospitals to provide inpatient and outpatient consultations, while beyond the hospital setting, there are community-based palliative care services or teams that seek to bring some of this care and this approach into the home. These services often look different in that these community-based services are generally less medically intensive, but may provide support in other ways, like child life or massage therapy, music therapy, things that traditional insurances may not cover. As a patient trends towards end of life, hospice may become a service that is introduced, and it refers to a specific care delivery model that specializes in end-of-life care and symptom management, particularly in the home setting. And finally, bereavement programs serve families whose child or loved one has died. So we'll spend the rest of our time describing different domains of subspecialty practice and kind of peeling back the curtain a little bit, getting you a little bit more in the granular details of what we do and how we do it. We'll describe in more detail how we support medical teams and families in clarifying prognostic understanding about a patient's illness. And how does this understanding then help families determine their goals of care for their child? And how can pediatric palliative care support families and teams to make decisions that align with these goals? How do we help families anticipate and plan for what lies ahead? How do we manage distressing symptoms that arise during the course of illness? As many of you have experienced firsthand, facilitating streamlined and consistent communication in a hospital setting can be quite challenging, and we're there to try to help. Palliative care teams are critically important to educate and support the medical teams to continue providing serious illness care, and palliative care teams often provide bereavement support as well. So when we think about the term prognostic understanding, what does that mean? I think one of the most common reasons palliative care is consulted is for us to help elucidate goals of care for our family. And you may have even heard clinicians ask you as parents, what are your goals for your child? To help them determine what to do next in their treatment. In our experience, we find that medical teams often jump to this step without first clarifying whether there's a shared prognostic understanding of the situation. So when we meet with families, a critical part of our initial assessment is to explore whether families and medical teams are on the same page. Is there information or are there knowledge gaps that need to be addressed? And we may ask questions such as, when we meet with a family, what have you heard about what to expect with your illness? Or what do you understand about your child's illness? We assess communication preferences. How do you like to receive information? What information would be most helpful for you right now? And how do you want to be involved in conversations about what to expect? Do you prefer big family meetings where there's all sorts of subspecialists in the room, or would you prefer it to be streamlined through one or two providers? This is an essential first step in identifying where we are in a shared understanding, both with the medical team and the family, before we then enter into discussions about goals of care. But why is this step so hard? Why is prognosis or delivering a prognosis or communicating about prognosis so hard? I think the first point that there's just so much uncertainty in the trajectory and the course of any complex patient, particularly children with heterotaxy, where every patient, every kid is individual and unique and different. There's just so much uncertainty that it is hard for the medical team, the ICU team, their cardiology team to give any information with clarity or certainty about it. But I do think, and we've all been in positions where we've seen patients do better than we expect. So, you know, the teams are human. They also want to maintain hope and establish that therapeutic balance, alliance with families, and don't want to take away that hope, even in the face of potential bad news. And because of these tensions, data does show that the medical teams tend to avoid conversations or defer these types of conversations. Only 3% of recorded conversations include prognostic discussions, and when they occur, many caveats and softening statements are included. Yet, a clear understanding of prognosis, what teams are worried about, what teams think might happen, greatly affects treatment decision-making, end-of-life care decision-making, and bereavement outcomes. So we understand that shared prognostic understanding is a process. It takes time. It's more than just one conversation. But it requires iterative reassessment over time. As more clinical data is available, that factors into how a medical team might conceptualize or think about a patient. And that also affects how that information and prognosis is shared. As a palliative care service, we are there to support and often coach teams to help deliver clearer and more concise prognostic information that can help families with establishing and thinking through goals of care and the future. So once there is a shared prognostic understanding, we feel that is what families need to be able to then truly explore and think about how that factors into their hopes and their worries and their priorities. We acknowledge and normalize the coexistence of many goals, and sometimes name that some of these goals may not be possible or may be conflicting in the context of complex medical decisions. And in thinking through that, we can anticipate and identify inflection points in which goals might require reassessment. We understand that goals of care aren't just medical goals. Families' goals are grounded in hopes, worries, values, and experience. Unlike medical providers, parents do not rely solely on risks and benefits to make decisions, but the goals of care represent a consolidation of parental experience, your emotions, your perspectives, and your priorities. There is emerging literature in different patient populations to help us better understand the patient and parental experience of living with serious illness. The most studied group is the pediatric oncology population, and while there are some similarities, we recognize that there are many important differences compared with other populations. There is not yet any cohort study focusing on heterotaxy syndrome, but there is a growing literature base that studies and describes the experiences and needs of the congenital heart disease population and medically complex population. I think palliative care, more than any other subspecialty, focuses on the illness experience. We strive to take a holistic approach in understanding what matters most to each patient and family, and to ensure care that is provided in a way that best honors these goals and values.
Thank you, Suni. As Suni started to kind of share with you all, the goal here is to really pull back the curtain, kind of share what does this look like? How do we and other teams like ours think about or synthesize, identify these goals of care? And so that always starts with the first conversation, the initial consult. This is kind of our framework for an initial consult, and most teams or many teams have a pretty similar framework. It starts with, tell us about your child. Tell us about who they are as a person, what makes them happy, what have you noticed about their personality. If this is an infant, we might ask, how did you choose their name? We really want to get a sense outside of the medical kind of diagnosis, who is this child and how do they fit into your family? Then, as we kind of talked about before, we want to get a sense of what's your understanding of what's going on with the clinical condition, or what have you kind of heard from the teams? The goal here is really so that we start from a place of shared alignment in this prognostic understanding. Given that, what is feeling most important? What are the things you're hoping for? Maybe in the short term, in the longer term. And on the flip side of that, what is keeping you up at night? What things do you worry about? These two middle questions really help us target in on kind of those values and those priorities that help give us context to how are we going to think about the next steps and what's most important. And because we are an interdisciplinary team coming from different lenses, thinking about not just the patient, but also the family and the community, we really want to know kind of where do you find strength, what is helping you now, and how are you getting by day to day. Given there's so much uncertainty, as Suni was describing, in a child's medical course, particularly in heterotaxy, we try to consider what inflection points might arise. These are time points where palliative care involvement may be additionally helpful, and there are also time points when, if palliative care is already involved, we might take a step back reassess those values and priorities that we uncovered and discussed in the prior initial consult or conversation. In this population, we might think of some inflection points, often starting with diagnosis, whether that's prenatally, early in infancy, at first surgical staging. Other inflection points we think about might be when the physiology has become more progressive or unstable, despite a staged intervention. And we also think about recurrent admissions, kind of due to the complexity and full body involvement of heterotaxy, or even transfers between and out of care units. Finally, inflection points that we think about are often when the anatomy seems no longer repairable, or cure, as we're calling it, is no longer possible. During all this, symptoms of advanced heart disease may drive additional step-back points. This brings us to this domain of decision support. So how do we get there? These goals of care that we've been talking about, particularly during inflection points, are really important. So we consider how to support families in decision making and offer or support the teams in offering clear medical recommendations that are based on identified goals and values. So, how do we do that? We often package what we've heard from families as goals into 3 buckets, though we recognize, of course, that every family is unique and that these buckets are more on a spectrum. As our former fellow, Dr. Amy Porter, wrote in her 2023 paper, she helped kind of delineate this. On the one side of the spectrum is this idea of living as long as possible. And on the other side is living as well as possible. And we find many people end up somewhere kind of in the middle of living as well for as long as possible. Understanding where families' priorities and values are then allow us to consider decision-making frameworks, focusing on what matters most. So for the family, where living as long as possible is most important, decisions and support around decision-making focuses on this primary goal of long-term survival. And the risk of side effect and symptoms may not outweigh a potential kind of intensive intervention, the potential benefit of an intensive intervention. Whereas for a family whose focus is more on living as well as possible, decisions might focus more on optimizing quality of life and even discontinuing interventions that may cause suffering, recognizing that time might be shorter. And finally, for that middle group, where most and many families end up falling, where living as well as possible for as long as possible is most important, this is where we think a blended approach to care works quite well, where each decision is made by weighing the anticipated benefits and burdens over time and considering kind of time-limited trials. We know from the literature, this particular study was published in 2017 by a group of surgeons, that when there are high-stakes surgical decisions at play, using communication frameworks like this one, which is a best case, worst case, most likely, actually changes communication, shifting the focus of decision-making conversations from an isolated surgical problem to a discussion about treatment alternatives and outcomes. Given our field is so communication-driven, we collaborate with the surgical and cardiology teams to help structure challenging conversations to promote shared decision-making, particularly in the acute setting. This idea of shared decision-making, we have more and more kind of understanding over time about how important it is, and that it may help reduce regret. In this study, which is published in 2023, Elizabeth Broden, who's a nurse researcher actually here in Boston, she asked bereaved parents to report whether they had decisional regret and gave them space to describe their response in more qualitative detail. The language parents who had regret used often contained phrases like, I should have. Should I have? Was there anything more? It hinted at an experience of self-blame in decisions made for their child. Meanwhile, parents without regret referenced a shared responsibility. They conveyed phrases like, we were guided to, we followed the recommendation of, we shared in this decision, we trust. And so part of our job as palliative care clinicians is to support this decision making, ensure it's aligned with family values and preferences, and to help provide recommendations that, given this evidence, promote shared decision making. You might hear us say or support a team member in saying, based on what you've told me about what is most important to you and your family, and what I know about this disease, I'd recommend. Shifting gears just a smidge. Thinking about other kind of domains of subspecialty palliative care, SUNY highlighted, started with this, but I think another space for us to think about is symptom management. And really here, we assess and manage physical, psychosocial, spiritual, and existential symptoms, and we tailor the approach to patient and family goals. We work in collaboration with other teams within the hospital and outside the hospital, and we have an expertise in end-of-life anticipatory guidance, assessment, and management, all again based on these goals of care, values, and priorities.
So I'm going to shift us a smidge again, as Chelsea said, and talk about the next domain that we support with in pediatric palliative care, and that is providing anticipatory guidance and engaging in advanced care planning. Now, providing anticipatory guidance means helping patients and families prepare for what might lie ahead, medically, emotionally, practically, right? Thinking about just logistics, right, of seeking care at an institution or closer to home. It involves proactively sharing information about expected changes, possible decisions, and how care might need to be adapted. The goal isn't to predict the future with certainty, right? As we heard both SUNY and Chelsea share, right? There's always going to be uncertainty in what's ahead. Although I think we all wish we had a crystal ball sometimes, right? And could predict that future. But to the best of our ability and knowledge, partner with the medical teams to offer a roadmap. And that includes discussions around treatment options, symptom management, supports, care location, preferences, and when appropriate, end-of-life planning. Now, advanced care planning is a natural extension of this process. It's a collaborative, ongoing conversation between the patient, family, and medical team that aligns future care with the patient and family values and goals, right? Like we've talking about, throughout this presentation today. And advanced care planning may include preferences around resuscitation status, treatment limitations, again, locations of care, also legacy building, how a patient might want to be remembered, and care after the end of life. Advanced care planning evolves over time, often prompted by changes in condition or goals, right? Reviewing these time points and with iterative conversations. So our role is to recognize these moments, create space for discussions, and use the available resources and communication tools to support patients and families in planning ahead. So I thought we would talk more about what some of these tools might look like, right? Kind of behind the curtain. And one tool we use to engage families is simple and powerful. And that is these what-if conversations. Now, these are gentle, open-ended questions that invite parents or caregivers to explore hopes, fears, the possibilities ahead. So you might hear us asking, I find that many families wonder, what if things don't go as we hope? Is that something you would want to talk more about today? Or when you wonder, what if things don't go as we hope? What comes to mind? And these conversations, again, are not about making any decisions right away, but really about helping families and caregivers think ahead so we can keep the care aligned with what matters most. And alongside these what-if conversations, we also use concrete tools like my wishes and voicing my choices to support advanced care planning with children's, teens, young adults, and their families. These are actually booklets, right? So you could actually work with your care teams if it makes sense to kind of work through some of these. And they offer a structured way for patients, if they're able to engage in this process, or their families, loved ones caring for them, to express what matters most, how they might want to be cared for, what brings them comfort, and how they'd like to be remembered. It can include anything from medical preferences to personal messages, spiritual beliefs, or simple wishes like what a child's favorite song is, or who they want nearby them if things are changing fast. And My Wishes here is designed for younger children, while Voicing My Choices is really tailored for adolescents, young adults. And for grown-ups, for adults, there's also a 5 Wishes advanced care planning tool document that I encourage all of you to check out for yourselves. But using these tools really helps ensure that the voice of the child, teen, young adult is heard and honored and a part of the care that we are planning. Moving forward to the next domain, we in pediatric palliative care help a lot with communication coordination. So that means our job is to ensure consistent communication around prognosis, illness trajectory, goals of care, and care pathways, right? What we learned a lot from SUNY from earlier today. We also help to facilitate collaboration across care locations, medical specialties, and time. And here at Boston Children's with the team that we work with, we have the privilege of sometimes supporting patients and families for days to weeks to months to years, and sometimes even decades. There are patients on our team we followed for decades, which is amazing to see the child and family grow with time. And lastly, we serve as a bridge, right? And that is for patient and family goals with multidisciplinary team assessment. We work as a subspecialty pediatric palliative care team, right? And often guide the primary teams caring for you or your child and making sure the care is most aligned with what's most important. All right, we're going to keep shifting along in the domains here. We're aware of the time. We also help with education and team support. And just to name out loud to all of you in the room, we are so grateful to be invited to the conference today and to speak to you all about how pediatric palliative care can be helpful in heterotaxy. So this is actually one of our very important goals. So thank you for having us. We love to provide evidence-based education so you all can learn more about what we do because there's a lot of misconceptions out there. We also encourage concepts and the practice of resilience to support professional engagement, meaning-making, and purpose. And one of our division chief, Dr. Abby Rosenberg, is actually one of the leading experts in resilience research. So we're incorporating her teachings, lessons learned into our clinical practice to continue supporting patients and their families. And lastly, we also, like to provide a lot of support to teams, right? The work that we do is often difficult. So being there to understand and listen to teams' concerns, offer that supportive listening, and really using what we know and what we can explore with patients and families about goals and priorities, right? Again, to really partner together to provide everyone the best care possible. And one of the most difficult parts of our work and difficult things to talk about, right, is bereavement support. Sometimes despite all interventions, everyone doing all of the things we can, sometimes children may die secondary to their medical condition, so a bereavement support is a part of our job. And through that, we provide anticipatory guidance about what to expect at end of life and immediately after, including symptoms, logistics. We ensure opportunities for legacy and meaning-making activities, exploring and enabling end-of-life rituals, what is most important to each and every family, and all of that is unique. And lastly, we provide support in the years to follow after the death of any child that our team follows. We have a program that extends at least 2 years, if not more, that we stay connected with families. And I just wanted to take us back to the community-based pediatric palliative care resources that Suni spoke a little bit about earlier. So here in Massachusetts, we've got a couple that are easy to access. The first is the Pediatric Palliative Care Network, and that serves children with life-limiting illnesses and their families. There is no cost for these services for a child aged 22 and under. And they provide home-based services such as a visiting nurse, social worker, and other therapies like music, art, child life, chaplaincy also comes by. And Courageous Parents Network is also an incredible online resource. Has anybody heard of it in the room? Oh, we got one down the aisle. Oh, amazing, thank you. You're getting a brochure now. But Courageous Parents Network is a nonprofit organization that provides educational resources, community and support for families and others caring for a child with serious medical condition. It was founded back in 2014 and uses both family and clinician-facing resources such as videos and audio stories, guides and blogs, even events and webinars, all designed to help navigate the challenges of a child living with serious illness. So we'd encourage you to check it out. So we hope you learned a lot from our presentation today, and just to kind of bring us back to when should you consider palliative care involvement, right? If there's complex care across any of the domains we talked about today, if communication challenges are coming up, if there are refractory symptoms that we might be able to help think about and potentially treat, if there are upcoming decision points, and really, anytime it crosses your mind, we are here to be helpful. We are here to be helpful. So without further ado, thank you all again so much, and we'll have time for questions. And if you could all take a moment and scan this QR code for us, we love to get feedback on our presentations and bring this back to our teams about the impact of our teaching, and sharing how palliative care can be helpful to folks like you. So thank you for completing that for us. Thank you.
If you have any questions, if you will come up and use this microphone up here, we're working on some wireless ones, but this way our virtual people can hear the questions as well. All right, well, I just want to say thank you so much. Palliative has played such a vital role in our journey. I highly, highly recommend that you look into it. It will look different what institution you're at. Some have inpatient programs, some have outpatient, some have both. Depending on where we have lived, it's been a tad bit different, but we have gotten support beyond my wildest imagination. Everything from a child life specialist coming into my home to work with my children, to providing organizations that help come and keep my house clean while we're in the midst of all these hospital stays, to having nurses and nurse practitioners coming to some of our appointments with us, to a desperate plea, as I've emailed them and said, our team is not working for us. This is so frustrating. It's all on my shoulders and I can't keep doing this. And getting an email back and says, I'm gonna call you. And within about half an hour, I had a list of doctors to add to my daughter's team to help take some of that off of my shoulders. So very, very highly recommend that you reach out to your local institution and figure out what their palliative looks like and what support they can offer you. I know in Salt Lake at our Children's Hospital, a heterotaxy diagnosis automatically triggers a referral over to palliative now. So very vital. When my daughter was born 19 years ago, this was not something that was really talked about. It was not something that we really even understood. And as I've watched the care evolve over the years, I have watched these kids fare better because we're seeing to all aspects of their care, not just the physical. So thank you very much. Appreciate you guys coming.
Thank you.
All right, shifting gears a bit here. How many times have you guys sat in a doctor's office and heard the words coming out of their mouth and thought, there's no way, like this doesn't make sense to me, this maybe not be the news that I wanted to hear, and just felt daunted, very daunting to get those words said to you that you're just like, this is not good. I remember so very clearly a time when my daughter was 3 and the doctor told me, you know what, there's nothing more we can do for her. Just let the TPN destroy her liver and wait for her to die. And I looked at them and I said, yeah, that's not going to happen. And I think that's something that as heterotaxy parents, we very much have in common, is that we're going to continue fighting. We're going to continue searching and looking for the better answers. Second opinions play a very, very vital role in that. And I am so excited to have Renee Harrell join us to talk about that. Renee is the Director of Programming at Heterotaxy Connection, where she develops resources, peer mentorship programs, and educational initiatives. She's inspired by her daughter, Serafina, and is committed to expanding our support for our families navigating the challenges of living with heterotaxy diagnosis. So without further ado, Renee.
Sorry, getting myself sorted here. Okay, I just, here we go. All right, I just want to say thanks to Nisha for the introduction, and also thanks to Dr. Liao and Chelsea and Lauren for that really great talk on the many benefits of adding palliative care as part of our children's care team. They're a hard act to follow. I'll do my best. But what they shared really actually highlights how beneficial it is when our kids have a care team that is looking at the whole picture from multiple different perspectives. And that's the same thing that's really at the heart of what makes second opinions so valuable and beneficial to consider for our child's care. So, why, right? Why a second opinion? When does it matter? And as we know, when our kids, when our kids are diagnosed with heterotaxy, every child is different. Their anatomy is highly complex. No two kids are ever the same, and that means no two treatment pathways are really going to be exactly alike. So that leaves our families really finding themselves, as Nisha mentioned, really weighing major medical decisions about what to do, with not always a ton of data or potentially maybe understanding about what treatment plans are even available, and that can differ from institution to institution because heterotaxy is so rare, expertise can be concentrated in different areas across different geographies, and finding the right person who can really speak to your child's specific anatomy may vary. So kind of the benefits of second opinions in a rare condition like heterotaxy tend to fall in about 3 main buckets. One, kind of a big one, is that second opinions can help increase diagnostic accuracy, again, because heterotaxy involves so many systems and is so complex. The value of an extra set of eyes can help refine a diagnosis or help find something that might have been missed, or maybe just not thought about or uncovered yet. There have not been a lot of studies on this, but there is some survey data that comes out of some hospitals, major tertiary centers that do a lot of second opinions, like the Mayo Clinic for adults and the Cleveland Clinic is another one. And I think there was a survey done, I think it was the Mayo Clinic, in which in their second opinion kind of referral centers, doctors reported back only about 12% of diagnoses were fully confirmed, 21% of diagnoses were completely changed, and about 2/3 of diagnoses were refined or expanded from where they initially started. There was also another study, the kind of a multi-system review, that came up with a percentage range of anywhere from 10 to 62% of second opinions led to changes in either diagnosis, there we go, a diagnosis, treatment, or prognosis. So, this makes a clear case for why having another set of eyes look at your child could really benefit an understanding of exactly what they have going on. And the second avenue, even when diagnosis itself doesn't change, we're having technical, I'm not the technically savvy person. Here, we're back. Oh, there's a connection problem. See, never ask me to run your AV. And the second one, even when diagnosis doesn't change, second opinions can often lead to an expansion of what treatment options are available to your child. And again, kind of looking in some of these same studies, one study showed about 1/3 of patients received a diagnosis or treatment options that significantly changed their clinical management. And I think as high as Mayo Clinic study, about 88% of their second opinion patients led to some type of changes to plans of care. And then lastly, even if your diagnosis doesn't change or your plan of care doesn't change, second opinions have been proven to be clearly beneficial to families' feelings of empowerment. Families benefit enormously by the fact that what they come out of this with is usually they feel more confident in decision making. They feel that they better understand their child's diagnosis. They feel more confident in their care plans and moving forward, and they feel more in partnership with their child's care team. So for kids like ours, this kind of increased understanding, increased trust in care teams, increased confidence in the decisions they're making, can really lead to benefits when trying to make some of these complex medical treatment decisions moving forward. So the whys, or the wins, should we say, there are certain inflection points in which, first of all, we should always caveat, there is never a bad time to look for a second opinion. There is no, at any point along your child's care trajectory, you can always feel that that is the right time to look for an opinion. But there are a couple of key inflection points, usually when there's a new diagnosis. That doesn't just have to mean the heterotaxy diagnosis itself, but maybe something's changed. Maybe a new issue has come up. They've been diagnosed with asthma, or something's changed about what their underlying cardiac diagnosis has been. Also, before any type of major medical decision or surgical decision, Maybe you're looking at cardiac surgery and trying to decide on timing and exactly what surgery to do. If there's any uncertainty in your care team about what the best pathway is going forward, as Nisha kind of referred to, if treatment isn't being offered, they're telling you there's nothing they can do for your child, or it's not going as expected, or even just as a gut check. Does something feel missing or unanswered? Are you just feeling uneasy with how things are going and you'd really just like a second pair of eyes to come help take a look? I'd like to, at this time, those are very clear reasons why to get a second opinion. There are some myths about second opinions that tend to make people maybe initially shy away from the idea of doing that. So we just thought we would try to talk about some of those. The first being the really big one, and number one that families and patients will report, is that if I get a second opinion that's going to say, I'm going to upset my doctor, right? They're going to be offended. They are going to think I'm saying bad things about them, or that this means that, I think they're a lousy doctor, and maybe this is a doctor you have a good relationship with, and you don't want to offend them. But the reality is, most doctors are going to support second opinions as a routine part of patient care, particularly when you're talking about rare conditions and complex diseases that benefit from multiple perspectives on their care. When it's, I think, actually important to note that the American Medical Association's Code of Medical Ethics actually has an explicit statement on second opinions, where they affirm that doctors should be supportive of a patient's request for a second opinion. And when they've done qualitative interviews of doctors, a majority of doctors talk about how they respect and affirm patient autonomy. And part of patient autonomy means the ability and the right to seek additional perspectives on their child's care. We are just... All right, we don't... Okay, all right, we're gonna keep doing this. So myth number 2 kind of ties with that, this idea that a second opinion will mean I don't trust my doctor. And again, as we said, good doctors want you to be comfortable with your child's care and are pretty open to this idea of getting a second opinion. But there's also the fact that second opinions can increase patient trust, confidence, and understanding with their primary medical team or a new team that they end up with. So the research, again, around this tends to tell us that patients who seek second opinions, who feel more confident and informed, are more at ease at discussing these things with their medical team afterwards. And by confirming or clarifying diagnoses, second opinions can strengthen trust with their primary care team, particularly if a second opinion is pursued in concert with your original care provider. The third myth is that a second opinion is always going to require travel. And for some families, right, they think this is not logistically possible. It's not like, there's 20,000 heterotaxy experts just hanging out in your backyard, just waiting for you to wave and flag one down. And so often, the experts that we were looking for in a second opinion might be further away. And the reality is, virtual options, at least when we're talking about initial record review, are widespread and available. And there are also times in which virtual visits can be arranged after an initial record review with some ideas for initial opinions, and then it can be determined at that point what kind of in-person visits might be needed to follow up with any of those initial impressions. The fourth one is that second opinions are costly. The truth is that, at least as we said, that initial record review, at least to form opinions, can often be free of charge, and there are established pathways for insurance coverage. So We often can kind of think of these as, that this is going to be cost prohibitive and that's not going to be possible for us. But particularly at major academic medical centers, at least again when we're talking about initial records review, this can potentially be provided to families at no cost if they contact a targeted specialty clinic that does this on a routine basis. And when in-person care is required, in order to be able to provide that in-person opinion, there are established pathways for insurance coverage, and we're going to kind of get into that one a little bit later. And the final one is this idea, again, that a second opinion is only for those who are dissatisfied with their current care. And obviously, because dissatisfaction is a very, very legitimate reason for prompting event for getting a second opinion, that leads sometimes families to, it leaves the impression that the only reason to seek another opinion is when things are going poorly. But even as kind of came up in the palliative care conversation, and in this one, that is just not the case. The idea is that when you have a child with a complex condition, two eyes are better than one. Sometimes you're looking for when you're making nuanced decisions, the more perspectives that you can have on your child's diagnosis and current treatment plans can really just help you to feel more confident in whatever treatment decisions you make. It doesn't mean that you change your treatment team. It doesn't mean that you have to choose a different treatment plan. It simply means that you're getting another pair of expert eyes to come take a look at what's going on with your child. So, if you've decided, maybe, a second opinion I think might be worthwhile for my kid, then we start with, how do you start? And the number one suggestion really, if you have a collaborative relationship with your child's care team, is really start with talking to your child's current doctor. And again, going back to this idea that a majority of doctors will support families seeking second opinions. So how do you choose the right provider of your child to talk to? The suggestion really is to look for the provider who is most involved in the clinical care where you have a question. So for example, if you're looking for a second opinion on a particular type of cardiac surgery or the timing of cardiac surgery, then maybe the person that you approach is your child's cardiologist. If it has something to do with their fever care plan, then maybe you go to the specialist who's managing your child's asplenia or polysplenia. Then we come to, how do you ask? The idea and suggestion is really to pick some collaborative framing that you are working in concert with your child's care team. Something like, we really value your care and expertise. We'd like to get a second opinion just to be sure we understand everything involved in what we're discussing and that we've looked at every option before we move forward. Finally, there are obviously, we acknowledge, sometimes, we get it. Not every doctor might be supportive of a second opinion or welcomes that, or sometimes you run into a situation in which you feel like you've lost trust or confidence in some members of your care team and feel it's in your child's best interest to not involve them in getting a second opinion. And then at that point, always just a reminder that it is your right to seek a second opinion for your child. You are fundamentally the ultimate decision maker, and it's your judgment that will determine, what and when and how to approach your child's primary care team at that. So how do you determine the right specialist to ask? Right? It's not like when our kid is handed to us with a heterotaxy diagnosis, they come along with the yellow pages that says, here are all the people who know about heterotaxy, and you just flip through and stick a finger there and go, I think this is the one, right? This is a process in which this is knowledge that's not always automatically accessible to us from day one. So what are some of our options? If you have a collaborative relationship with your child's care team, asking your child's current doctor, right? Saying to them, hey, is there somebody you would recommend? The benefit of that is These are people who know your child's care very well. They're very intimately familiar with your child's individual care process. And hopefully they're in connection and relationships with their colleagues who they are familiar with, and then can really use that to your benefit by providing a good match, and then they can have behind the scenes conversations that can really help advocate for tailoring that second opinion to the question that you have. Other ways to do that, if your current care provider doesn't have a suggestion, if they're not really familiar, they're unsure, there are ways to review hospitals for data on the volume of patients they see for the particular issue that your child is seeing. You can check to see, do they have multidisciplinary clinics that involve whatever organ systems are involved for your kid that you are looking for an opinion on. What kind of heterotaxy experience do they have? Do they have a heterotaxy clinic? There are also some public databases that you can check for certain types of institutional outcomes. So the Society of Thoracic Surgeons operates a congenital heart surgery database that gives data on outcomes on a whole array of commonly known congenital heart surgeries that are done. You can also become your own Sherlock Holmes. We've all done it as heterotaxy parents. You can search published literature in places like PubMed or Google Scholar to identify people who are publishing on heterotaxy. This can just sometimes help identify experts who are active in advancing heterotaxy care and really have an interest in treating heterotaxy patients. And finally, woohoo, here we are, we're doing it right now, connecting with other families and organizations who are really involved for guidance, right? And we don't pretend to be medical doctors, we don't play one on TV, at least I don't. We don't have medical authority, but what we do bring to the table is actual lived experience. And that is what we can share together as a community in which, we reach down to the patient family that's next to us when we have experience that we can share from what it's like to deal with these particular medical institutions or doctors from a parent perspective and how that's impacted our child. What kind of questions to ask? These are just some of the suggestions of kind of how you could approach that for a second opinion. You usually want to start with, what is your specific question? So, hey, I am hoping that you might be able to weigh in on fill in the blank, what's applicable to you on my situation with my child. And then, this relates to these. How many heterotaxy patients have you seen? Oh, there we go. How many heterotaxy patients have you seen with a similar diagnosis as my child? What kind of testing or records do you need before you can offer an opinion? Is travel required? What is the expected timeline for receiving the opinion? How will your opinion be communicated to us? Will you talk to my child's current care team, or would you expect me to do that? What are the costs involved? Who in your office might help with getting insurance approvals if that is needed? The next thing, and one of the typical biggest holdups in getting a second opinion, will often happen to do with medical records, right? Getting them from point A to point B can be a rather Herculean task, as we all know. So again, some of the suggestions, if your current team is collaborating with you, asking your current provider to do provider-to-provider records transfers if they can. That's going to be quick and efficient because they can really bring the second opinion provider up to speed very quickly on exactly what's going on and really know what kind of documents would be most helpful to that second opinion provider. Obviously, if you've been maintaining your own records, that can be enormously beneficial. So if you have always been keeping up with all, major documents on operative, cath, imaging, discharge reports, hospitalizations, kind of, if you have that in the background where you're keeping your own records, this will be a great way to save on time waiting for records if you come to the point where you're seeking a second opinion. You can leverage patient portals and EMRs in these days. You can download visit summaries, test results, provider notes. Some EMRs now are coming out with ability to data share, like You can give explicit permission between two hospitals to securely exchange records, so you can always ask if that's an option. And really just keep checking your EMR to make sure that it's being regularly updated with all the information you need. For information that's not on your AMR or that you don't have in your own records, there are formal record requests that you do. Sometimes you can do that online, sometimes you have to fax or send in paper, like we're in the olden days, to the health management system at your particular hospital. And so you would want to file those. There are special considerations for imaging and radiology. You just want to make sure that you are requesting full imaging files, typically in DICOM format, not just written reports. You want to see if your hospital can do this digitally. If they can't do it digitally, requesting a CD and confirm that wherever you're getting the second opinion can actually open and read the format that they're giving it to you. And definitely try to keep a copy, a permanent copy for yourself as well for your own. Oh, my computer is just not liking me today. For your own records. You will want to follow up if you've made any records requests. Note that hospitals are required by law to give you your records that you have requested within 30 days. If that doesn't actually happen, there are pathways at the hospital or with whoever is providing the records to escalate that further. All right, and then we move on to the next fun stuff after medical records is understanding insurance coverage. We are going to have a whole separate talk on insurance later, so I don't want to kind of dive too much into that, just kind of talking about this as the coverage relates to the second opinion process itself. So we talked about early, sometimes initial record reviews can just be provided at no cost. But there are times in which you might need to have an in-person visit, specific testing or treatment is being requested in order to be able to provide you with the second opinion that you're looking for, and then that's when insurance coverage would come into play. So you would want to confirm with your insurer to verify that second opinions are covered. As an FYI, most major private insurances and public insurances, including Medicare and TRICARE, actually specifically cover second opinions as medically necessary, particularly when you are looking at a surgery or a major treatment is being recommended. So you would specifically mention this to your insurance company that you are looking for your second opinion, because that will trigger a certain category of coverage that you will be discussing, and you'll just want to confirm that coverage in writing. Some will require pre-authorizations. There can be issues with in-network and out-of-network coverage. You can request an exception because, again, as we said, there's not 100 heterotaxy experts hanging out in your backyard that you can just pick one and go. So if the expert that you need is not in your child's network, you can request an exception because there is no one in a network who could provide that opinion. That could usually need some supportive documentation from either your second opinion or your primary referring provider for that. And there are a whole bunch of challenges and caveats to that, but we are going to leave that to our amazing Allie, who will be doing our insurance talk a little bit later today. And so that finally just kind of leads us to our bottom line. And really, it's that the evidence is overwhelming that families who seek second opinions, no matter what the outcome of that second opinions are, feel that they walk away with meaningful benefit. They report increased knowledge, increased confidence, and a high level of satisfaction with their care. Some surveys consistently, 90 to 95% of families who seek second opinions report being satisfied with their experience and say that, more importantly, that their questions were answered. So families who pursue second opinions and otherwise actively engage in shared decision-making, Global Genes did a study, and these are families who report greater confidence, and they are twice as likely to describe themselves as well-informed and empowered in their child's care. So if or when you choose to seek a second opinion, you can feel confident that it can be a valuable and worthwhile step for you and your child. These are just a couple of resources listed up here that are not necessarily second opinion specific, but Global Genes has a couple of really great resources on becoming an empowered patient. The Patient Advocacy Foundation is a place that can help when you have insurance issues, particularly as it relates to secondary opinions or care that is a little bit more complicated. And then that's just the note for the Society of the Thoracic Surgeons Congenital Heart Surgery Database. And so, any questions or whatnot? Again, I'm Renee. You can also find me hanging around. But otherwise, that's all I got. Yeah. Oh, question?
Very forward podium for questions. Thank you for your talk, Renee. That was wonderful. My name is Steve. I'm one of the clinicians. But I was thinking during the last talk and then even more during your talk about what do you see as the role of now or in the future AI summaries, like going to ChatGPT and not asking for a second opinion, obviously, but like for communicating such things or educating yourself about specific items of care. Have you seen this done? Do people talk about it? And what do you think is the role of that in the future?
This is personally speaking, yes, I do think families are absolutely going to places like ChatGPT to ask. I think, and obviously the hope is that AI continues to get better and better. There can be more accuracy. I think a lot of families that I'm hearing, they will use it, for example, to come up with questions that they have. I've heard of a ton of families who will put a report, be like, I just got this report full of medicalese. I think my daughter actually did that. So I in addition to my heterotaxy child, I have a 19-year-old daughter who also has congenital heart disease. And she went to one of her first appointments without me. And she was talking about the appointment, and then she's like, I don't know what any of this says. She's like, so I asked ChatGPT to tell me what all of these terms on this meant, and then I asked it to tell me if I should be worried. So I was like, great, glad to know, Dr. ChatGPT. But I do think it's important that doctors are aware that patients are doing this. I think particularly younger patients, and I'm not saying in my daughter's case, it clearly was, I think, I'm trying to be an adult, and I'm trying to figure out how to do this on my own, and that is a tool that she used. I do think a place for our patient organizations, it probably leans in the fact of saying, obviously, right, ChatGPT is not actually a doctor, and we do actually want to encourage our families to be having face-to-face conversations with their doctor, and taking these things that maybe they get, because we do obviously know that at this time, the way these models work is as large language models, they're sort of accumulating all of this data that floats around the internet, and that doesn't mean that it's the most up-to-date information. And it doesn't necessarily mean that it has to be accurate information, because ChatGPT is not assessing the validity of everything that's forming in here. So I just think as an empowerment tool, as a way to come up with conversation starters for our doctors, that's probably beneficial, but we obviously would want to encourage our patients to not use it in substitute of their doctors.
Extending the whole AI thing, one of the things that we've experienced with Heterotaxy Connection is searching for publications, and everybody listening, some of you already know this, but just caution that we have been given sites references to things that don't exist or that are completely bogus. And so that, as a parent and an experienced parent, that's one of the things that terrifies me, and I'm sure the medical community probably feels the same, that being misled. So definitely check your sources and bring those sources to your doctors face to face, because that's the best way
Yes.
to vet whether it's legitimate or not.
And I would just add, it's helpful to understand how these models work to know why they come up with citations. And the reason why is because they're a predictive algorithm that makes what is the most likely next word to come after this word. And when you're talking about medical stuff, right, what usually comes with medical stuff will come a citation, right? Like so when they've scraped the internet for that and they're making a predictive algorithm, then they make the predictive algorithm of what the citation is. So if you're not careful about how you're prompting your chat GBT or your AI to answer your question, and an easy way to then double check your sources is to specifically request that it give you a hyperlink to what it is that it read and tell you to find exactly where in there. Because the other thing it sometimes does is it will give you a legitimate citation, but the thing that it tells you is in that article is not in that article. So it just sort of like gives you a citation and attaches it to something that actually has no bearing on what it just told you to do. So that can just be helpful to understand how that kind of AI piece works in that part of that. So always verify, and you know, even if you're using it as a conversational tool to build confidence and build kind of what you feel is your ability to understand your own medical condition, just always try to make sure that you're verifying it independently with somebody who would have expertise for that. But it is important to be aware, as a doctor, you might have my 19-year-old daughter who comes in and says everything's going great. Like, yep, I get that. And the first thing she does is going to go ask ChatGPT what it is that you just said. So, any more questions for me? We're good. All right.
Thank you so much, Renee. I feel like we need to do an educational webinar after the conference on AI and how to use it. So we will get that in the works. I do know that if you are going to use AI, please make sure you can actually tell them which sources to pull from. So search known institutions, search PubMed. So cap that, as well as make sure you put the references in there and click on said references. I was pulling a report, I was working with Dr. Spurgeon to pull a report of just people that had written papers on heterotaxy, and the first one I pulled up, I'm like, wow, there's like 1,000 papers on PubMed about this. And then I start clicking on the link and it's like copper poisoning and all of this. It was not quite right. So do be cautious there. But there are some amazing things we can use it for, and we'll be talking a bit about that later this afternoon. One of the features, because I do have a 19-year-old heterotaxy daughter, and she does use AI. So how do we use that safely and make sure that it's not giving us false information will be a great webinar. So appreciate you, Renee. Second opinions can change the course of your child's life. There are definitely different ways to utilize those, but we highly, highly encourage, even if you're confident in what you're doing, if you talk to Allie out at the registration desk, she will tell you, I knew exactly what my child's path would be. I was very confident about it, and then I got a second opinion, and it changed how we approach things. So highly recommend it. Just if nothing else, it gives you the confidence to stand behind the decisions that you are making. We are going to break right now, so feel free to go get some coffee, some drinks, use the bathroom, check on your children, whatever you need. We will be meeting back here at 10:30, I believe. Yes, 10:30. So until then.
So I just like plug it in? So I do have a question. I mean, lots of questions. Where have you been all my life?
Well, I make them up.
So when I do a PowerPoint,
Yes.
and I just wanna, I wanna be able to see my notes, but I don't want my notes up there. How do I do that?
So that's, I think, I'm assuming I'm seeing you right now, so we'll see if we see you right now. Let me see. You, is this your,
This one?
I'm just gonna.
Nisha, how many people are online? 4. Because I'm trying this thing. I've never done it before. The Mentimeter. Have you ever seen Mentees? They're really cool. But people like put in a code and they can put in answers and then it shows up on the slides. So, but I've never done it. So I'm like,
How many people are what?
online because
Oh,
they can do
online.
it too because then they also
Yeah, I
can
love that.
participate in it and the people here can too.
That would be an Alan question. I don't know how.
I've never ever done a Menti. I just like put them in my slides and then I'm like, maybe it will work, maybe it won't.
Try it out.
Yeah,
I'll like it.
but like then they can still kind of participate.
Yeah. Yeah. So Alan would be the one to ask about.
Who's Alan?
Allie's dad.
Oh, the guy that I was sleeping.
Uh-huh.
I was like, you and me both.
Yeah.
Let's just nap. Let's do this.
What time did you get in?
The flight got in at like 11, and then I got to the hotel like
Copy that.
quite a while after.
We got in at
Ah!
yesterday morning. So, yeah.
You're like,
Just wanted to say hello formally. How are you? Good to see you. I have a couple of them. Okay. This is amazing. We can stop it, but I doubt it does an issue.
I figured as much.
you can close out that photo. And you can close out the doc too.
Display settings are not fully cooperating. Not sure. Alright, see what are your settings here. So we can go to desktop and just right click. I did. It's not working.
Yay! Wait, do I see? And then if you go then, well, there's no notes for the next couple. Oh yeah, the notes are there. Perfect. Okay. So if I go like that way, I can get bigger notes.
Yeah, so I can do this, increase font size.
How did you know my vision isn't great?
Happens to all.
I went back to school, and when I went back to school, I had to get bifocals.
I don't get old.
So now I have one contact that sees close and one far. Have
Oh,
you
you-
heard
oh, you
people?
do-
I have the
oh, yeah.
monovision. That's what I have. So if you see me going like that, that's the up close. That's the far away. No, so you just cancel out, but you lose a little depth perception. But I couldn't. It just didn't help. Like, so this is the only thing I could do with contacts is have one that sees close and one that sees far away. And your brain,
Learns through what
yes. But if I can't switch between bifocals and contacts quickly in a day.
Okay.
Like, I just kind of have to like ease into it. Isn't that the weirdest thing? But I'm like, brains are wild.
Very adaptive. I'm gonna see if it saves the settings for future, then I'll show you how to get to it.
Okay.
So the trick is having being an extended desktop.
Mm-hmm.
So
I saw the updated ones look pretty.
it's there. And then we go here and down.
Yay! Oh, excellent.
So this is current slide, that's next slide, you can make any of them larger,
Okay.
smaller, you can make notes. Essentially all you do is just drag, that list.
I'm also gonna try something that I don't know if it even works.
Yeah.
So if you go to the second slide,
I mean, I think the structure.
it's a Mentimeter. And so people put in that code and then it makes like a word cloud and they answer like live.
Yeah, so they have to have the
Code.
The
I know
code,
sometimes
they
there's
have
like
the
a
code.
QR code, but I don't have that.
should be able to go to the Mentimeter website.
That's what they have to do, and then they have to put that in. So maybe I should like tell them to do that first.
Yeah, because they have to go to the website.
Okay, let's write down the code, and then I'll put it on the first slide. Maybe that's the best way to do it.
Yeah, so I'll do the code. So if you don't do a QR code, you need to give them a website to go to put the code.
Yes. So I need to put the website, and I need to. Oh, I didn't bring your pen. Is there a pen in here? Yes, they thought of it.
You have one, okay.
They gave us pens.
You need paper?
Well, I need to. What I should do is I should copy and paste
Yeah, I'm gonna
the
clear your
website.
Yeah.
Is hello? Are you gonna work? It doesn't like it. Is it because it's too dark? Why is it not connecting? Maybe I didn't sync it, and I synced it with my work laptop. Is it connected?
Oh, I'm sorry?
No, it hasn't seen them yet. Yeah, it's right next to you.
Yeah, that's how I connected. So hold on.
Yeah, it looks like it's looking for it.
Maybe I'll just have to say.
Yeah, going to you files, because there's a lot of, out west, and it would be great for when you add a device for Bluetooth in Mississippi.
Yay! Okay.
Done?
Oh my gosh, where's my? Did it go on me?
What do you look for?
My mouse. Where's my arrow?
Oh, okay.
Where is it?
Or maybe on the.
Oh, there it is. Okay, yeah. Sometimes it goes like this. So to do a Menti, what code do I give? Probably like just Menti.
Yeah, I always feel great when I fly.
Then it's always like journal live presentation. Like from there.
So yeah, you gotta give them that Mentimeter.com and then enter the code.
Oh my gosh, why is this mouse so crazy? Do you see the arrow?
Yeah, the extended thing is over here, so if you drag it over that way.
There we go.
Yeah.
So I want to go from the first page. I'm going to add in that. I want that, and then I want the code. This is where we have to write it down.
Okay.
Oh, no, I can't see that.
Take a photo and then you want to go to it, I'll,
At the very top of the slide.
See that little teeny one?
Yep.
You can see that?
There we go.
Okay, so the code is what?
Yeah. 6398
6398.
4447.
Oh.
Yeah. I did change the settings. However, it could be something additional as well, but since your settings are what it won't let us get back to the email. But here's, we're still at like, didn't go to sleep until like 5 minutes, so I don't think that was the issue going on.
Yeah, it was like blinking out.
Yeah,
like,
I'm a
when
very
it was
like,
up
oh, I
here,
find your
even
name
on
on
my
the website, I'll email you,
screen, all
hey,
of
you
a
want to do
sudden, it
this?
was done.
You can
Well,
get
one
pretty
thing,
quick.
but the other thing, depending on plug in power, that you override a lot of things.
So plug in power there, and then your adapter there.
Okay. Do you have some power?
You can get power supply,
Yeah.
power is there, but we need power.
Okay, I can go grab my power.
Yep. Yeah, we can help you from that point if you have your.
Okay, yeah, so I'll go grab my power.
Yeah, that would.
So when I go onto like the conference Wi-Fi, it says it's not secure, which is true, right?
Yes, correct.
But like, so then like none
Then
of
we
my
need
websites or
then-
anything will work.
Correct, we need a code to get into it once we have the conference Wi-Fi.
What is the code?
That, I don't have, so they putting out.
Nisha, what's the conference? Oh, she's not here. I'm like, I'm like looking for you that way. I'm like, where you go?
Right here.
What's the conference code?
SDM 275.
Well, I'll have to do that though. But I didn't put anything in. I guess it's on. Okay. That was-
Okay, did you need this any longer?
No. And why did hers like keep glitching out?
So I looked at her settings, it didn't look like anything was setting. Sometimes Macs can not like adapters, so that's possible that it's in that. You don't have an adapter, so that's
Okay.
an issue for you. But you just need to make sure that also that your settings in here, like if you're not plugged into power or something, it doesn't just automatically go to sleep or dim or something like that.
Okay. There's a problem with the website certificate. That's why it's not like saving it. Okay.
Yeah. Yeah,
Maybe I'll just make these really big.
And is there any audio embedded within your presentation?
No, I'm not that fancy. But I don't know if the thing will work where it like
Yes.
does work live.
Yeah.
But I
You're
think,
not up right now.
okay, that's what I was like, is that, I think.
Okay, yeah, I like that. Yeah.
Okay. My mouse will always float away. But I like being able to like click on things. Okay, I think that's good.
Feeling groovy?
Yeah.
If you are able to go into your PowerPoint, I'll make sure that I have it on this and it's showing the correct one.
Okay. Do you want it in the presentation mode?
Yeah, so how you're going to present it.
Oh, it's like all. So it said that I can't sign in. So that's the other thing that I'm like, oh shoot. I've just been hotspotting off my phone all day. Because it doesn't let me like do anything.
Okay, let me check that I have you here. I do see it.
Huh? It does, but it's not secure, so it like doesn't let me get on to like my Microsoft account or anything. Like if I was at work, I'd use our VPN to like, but I don't have that on my personal. So.
All right, welcome back, everybody. We'd like to try and stay on schedule as much as possible, so we're going to move on. So our next speaker is going to talk about neurodevelopment, understanding how treating congenital heart defects, especially complex ones, impact neurodevelopment. Amy Libert is going to be presenting this, and bless her, she has stepped in last minute to help us with this, so very much appreciate it. Amy is a heterotaxy parent and a clinical social worker with a unique skilled nursing facility whose mission is to help children leave the hospital sooner, provide families opportunities to practice medical caregiving skills in real-life settings, and offer wraparound support as children transition home. We are so grateful for Amy being here and for being willing to share that expertise and knowledge with us.
Okay, can the folks online hear? Are we sure of this? Yeah? What you're gonna wanna do, I've never done this before, so it might not work, probably won't. But if you can go to this website, then you gotta put in this code. I know there's homework. And then give me a thumbs up once you have it. And then I'll be like, yep, we're good. It's like a ton of numbers. Usually there's a QR code, but I couldn't figure that out. I got one thumbs up. Anyone else in? Uh-oh, it's too hard. So what it does is it makes like interactive slides and polls, so I can then have you answer. Okay, who knows if it's gonna work? No idea. All right, go ahead. All right. So real quick, let's see. It's not showing the slide, is it now? Oh no. All right, what I'm gonna do is I'm gonna connect on my phone, I think. Do you see the first slide that says, what do you think of when you think of neurodevelopment? No, when you put in that code, what do you see? Well, it was a cool idea. My biggest problem has been the internet. I'm gonna try hooking up to my. It doesn't show anything, does it? And when you log into it, it doesn't give you anything either? Well, that's a shame. Okay, so the people online can only hear if my voice is like right on the microphone. But the first question was, when you think of the word neurodevelopment, when you hear that, what do you think? All right, nothing? Yes, Monica. Neurodevelopment makes you think about how the brain grows. Yeah? Anyone else? Some of us get twitchy. I hate the appointments. They're really long. Sometimes it's super stressful. It's a lot of like going in and hearing where your kid isn't the same or where they're behind. Neurodevelopment too is like sometimes really complicated, and I worry that it's like permanent. Does it mean new diagnosis? Does it mean new doctors? What the heck? Yeah. I'm so sorry that that slide didn't work. That was like my biggest hope. I was so excited for this. I'm also presenting on Sunday. I'll have it up and running by then, promise. Okay. So, just really quick, this is the substitute teacher edition of neurodevelopment. Like I said, not a neurodevelopment provider, just a clinical social worker. I do developmental assessments that help our kids get, in my state in Washington, get DDA, but I'm not an expert on it at all. So really quick, just a little bit of my background. I'm a heterotaxy parent. It's my son Christian in the picture over there. He was in the hospital for a year at Seattle Children's between the ages of 2.5 to 3.5 and waiting for a heart transplant. After his transplant, didn't quite take, and he ended up dying 3 months later. After he died, I became a medical foster parent. So in the bottom, that was me when I first had 2 tubies at once, and you can't totally tell from the picture, but I got puked on in the picture, and our nutritionist was there, or our dietitian was there, looking at both of my tubies, and I was like, I don't know what I'm doing. So I've had lots of kids that are medically complex, and then I went back to school to get my MSW. I started off as a recreational therapist, and then for those that haven't seen my kids in a long time, that's them in the picture. They're huge now. So the kids at home are 20, 18, 16 next month, and 8. So my goal isn't to make you experts in neurodevelopment. You are already that in your own families. I wanted to show you why it matters, where to go for help, and how to reframe disability and development, and how to find joy and delight in our kids right where they are. So in my current role, which is a super cool job, I help kids who have lived in the hospitals for months or years finally transition home or to a lower level of care. So we have kids that have been in the hospital usually around at least 6 months, and we've had kids that have been in the hospital 5 years, 8 years. And so our skilled nursing facility was created as a transitional place to help get kids out. Most of them are trach vent kids. What I do, I call it hospital detox. So, you know, it's so interesting. We get kids, they come from the hospital. It's like the first time some of them have ever even been in a car, right? They go outside and they freak out because their life has been the world with the ceiling. They haven't felt the wind outside. They haven't seen kids running around crazy. They haven't been to a playground. They haven't experienced a lot of stuff. So we just take them out everywhere. So in the picture, that's my daughter. She comes with me on outings sometimes, and we were helping a kid who had never been to McDonald's go to McDonald's and go to the play place. And it was a kid that was just learning to take things orally, who was about her same age. And so she's such a, I want to say it's not manipulative, but it's really smart. She said, Mom, I think she probably needs some ice cream. And I was like, yeah, she does. And so my daughter she got an ice cream and she was like licking the cone. And wouldn't you know, the other kid started licking the cone, started playing on the play equipment. I just bring my kid to like be our little social peer model. So I have a really cool job. We do wraparound, and then we visit and stay with families after they go home. So I continue to do home visits to make sure they can stay out of the hospital. But my absolute favorite part of my job is taking kids home for a visit to start. And it might be the first visit in a really long time. We had a kid who hadn't been home in 8 years who got to go sit in her room. Or sometimes it's the very first time the family has even had the child in their home. So it's just this really sacred space, and it is the best part of my job. I don't share a picture of what it is for a while I'm with families. This is actually a picture of us when my son had been hospitalized for maybe like 3 months. They gave us, we joked it was a pass, but he went home for 10 days. And we got home at like 11 o'clock at night. And you see the dude yelling? It's because we were playing his favorite video game. We're all super tired and done for the day. But he was so excited to be home and to play his video game. And, you know, I watch parents go through all these emotions. First, they're like flustered because the house isn't clean enough, or they're sad because the kid hasn't been home. And then they'll be so happy, and I realized, like, there isn't a word for the feeling, but the best word I can come to is they feel whole, to finally have everyone in the house. Okay, I don't think I'm going to do this in enough time. I'm going to skip slides too. Okay, so neurodevelopment isn't just about milestones. It's about brains and relationships and how they grow together. Hospitalization, medical trauma, and sensory deprivation can change how kids develop, but we can make a big difference once we know what to look for and where to go for help. One really great guide, and I have a link at the end, is just the CDC's like milestones to look through it. It just gives you just an overview of it and what skills usually typically show up and when. This is so hard, especially for the parents that I work for, because when you see the developmental age of your child and not the chronological age, it hurts so bad. And so I really, really emphasize with parents, it's not about comparison, it's about communication. And it helps you describe what you see to schools, doctors, and therapists so they can respond effectively. I think some of the hardest parts are when your kid's development doesn't match what you would assume by looking at them. So parents should know about neurodevelopment because it helps us change how we work with our kids. It gives us a shorthand, right? And knowing if your child has a development difference doesn't label them. It unlocks supports and it helps others meet them where they are. So a really big part of it is I have to tell parents, like, look, we're playing the billing game. I need these diagnoses that I'm going to give your child in order for them to access these services and to get it paid for. If that's all we're going to talk about it as, just think of it as like, this is what we do, and I hope my kid really is lower than we thought so we can get more services. Try and think of it as the game. So, kids with complex heart conditions are at higher risk for developmental differences. There's lots of factors here. There's genetics, there's the kids that are cyanotic with oxygen flow, there's being on bypass, there is the environment too. The good news is monitoring and early support make a huge difference. Some hospitals, like the one that we're partnered with is Seattle Children's, they've started a neurodevelopment clinic that wasn't around when my son was around. So important, and they have a single ventricle clinic for neurodevelopment. Really cool. So the big thing is look for neurodevelopment at your local children's hospital, and then also look for any cardiac neurodevelopment clinics. This slide, the next two slides, I'm going to skip over. You can spend forever reading them. I'll give you the link to my presentation, and you can look over it later. Okay, so remember I was a recreational therapist first. I don't know if I said that. And then became a social worker. But the really big understanding that you need to get where I'm coming from is the model of disability, okay? There's the medical model of disability, and then there's the social model of disability. So the medical model sees disability as something to fix, or something that is a deficit, or that needs to be treated, like in order to cure it. And the social model says that the person isn't broken, it's just that the world isn't accessible enough yet. It's more about like what people's access needs are as opposed to what they can't do. One of the big things that I always push is interdependence. Okay, we push so hard for our kids, especially I go through this to my kids at school. They always want her to be independent. And I'm like, no, I want my child to be interdependent, where she knows how to express what her needs are, and she knows where she can go for help, and that she can also have a sense of feeling like she can do things with help as opposed to do it on her own. Because there are some things that my youngest just won't ever be able to do. It's really important to do this because it shifts our understanding from what's wrong to what is needed. So remember that a diagnosis just really isn't a label to fear. It's a key to accessing services, therapy, and sometimes even belonging. Many late diagnosed people say they finally feel relief once they get a diagnosis, realizing that nothing's wrong with them. They just needed environments that fit their brains. Example, I asked my kid too if it was okay to share. My third kid was diagnosed with autism when they were almost 13. And we sat down with the team. We did this ADOS. So it's a big, long, long, long study. Sat down with this big team. And they were talking to Lou. And Lou was just like, I knew it. I finally feel like I belong. I fit somewhere. This makes so much sense. And it was such a relief. And then instead of saying that my child has autism, my child said, I'm autistic, and made it a part of their identity. This is another Mentimeter slide, and I'm so bummed. I wonder if I hit that start, if that will work. Oh, okay. It's a poll. So you could say why you struggle to access neurodevelopmental services and what the barriers are. So we could look around and be like, me too. So sorry. So another lovely late diagnosis story is my own. So genetic inheritance and better diagnosis resources leads to a lot of parents also getting diagnosed. I see nods in the group. So my diagnosis came after my kids, and that is that I have ADHD and that I also have different, because I never got it diagnosed, they're not learning disabilities, but they're learning differences, how we phrase it. But together, my kids and I have learned to understand our unique brains, and we have learned to embrace interdependence, to rely on one another's strengths instead of measuring our worth by productivity. One of the biggest things, if I could go back, I cannot emphasize this enough, is internalized ableism. Does that make sense? So what that means is I carry within me this belief that I am lesser than, I'm stupid, I am lazy, I'm not paying attention enough, I just didn't work smart enough. I got through my undergrad, you know, I have a bachelor's without any extra helps, right? But I worked my butt off. And I had tutors because I was an athlete, and so we got tutors for free. So I had a tutor in like almost every class. And so I got through college with a lot of activity and tutors and a lot of support, but I had a lot of moments where I just barely made it. I couldn't take tests. After I was sitting through one of my kids' appointments with their med provider, I was like, these questions are so dumb. I don't know why we ask them. Everyone thinks that way. The provider said, well, Amy, do you know how, prevalent it is to have genetics play a key? And so she's like, and we know Ty, which is my husband, and then there's you. And she pointed at me, and we all busted up laughing. And all of a sudden, it made sense, right? So embracing this diagnosis made a difference. And then after my son died, my brain was especially scrambled, and I just could not function. And I recognized all this stuff. I recognized the signs. I went and I started medication. Oh my gosh. I didn't know that's what everyone else's brain felt like. It was, there's a comic I'd love to share, I'll share it later, but of just that you're walking upstream, wading in water your whole life, and don't know that no one else is even in the dang water. Like, you just don't know what it feels like. So once I had medication, that made a difference. And then when I went back to grad school, I used student disability services. And I learned that I have to talk through things. So I went to all my papers. I go to the writing center and we just talk through all of my research papers instead of me having to form it in my head and then write it. And then the way I worked with projects and stuff totally changed. I have dyscalculia, and so they did adaptations for math. I finally understood statistics. Every research study I read, I always skipped over that section. And all of a sudden I was like, hot dog, I get this. It makes so much sense. But it wasn't until I worked with how my brain works and leaned into, I am gonna do it differently, but I have strengths in these areas, that I actually view myself as someone as worth. So one of the funny parts about why my kid was diagnosed so late is because our home has so many adaptations and accommodations. Because our 8-year-old also has autism, but in a higher degree. And so there's a lot of stuff that we're doing, but we didn't even think of it as an adaptation. One thing I would really, really love to do is maybe have a thread or something where people could just say, this is what we do in our house. You know, where there are things like this just makes sense? I would love to see what adaptations you have in your homes, because you're doing it, but you don't even think it's different till you go into someone else's home, or someone who hasn't been in your home is in there and they're like, what is that for? And you're like, duh, doesn't everyone have this? Yes, I love that. And then ideas of like what you do. I do like all my meetings at work with fidgets. I do a lot of stuff at home, and then there's just a lot of things. I'd love to see what you do. So this is how understanding how your kids' neurodevelopment and understanding how they work with it helps you when they're accessing the medical system. So here's an example, and I got permission first, from my now 8-year-old Kay. So we went to a new PCP, and Kay had a full meltdown. I picked her up midway through the school day. I ruined her routine. We went to a new doctor at a new building, at a new place, and nothing was right. And I thought she was going to be fine. Spoiler alert, she totally wasn't. So she hit a full sensory overload the minute we walked in. The lights are too bright, the sounds are too sharp, everything's unfamiliar. And then she started yelling. This is hilarious. It is to me. I'm autistic, and you broke my routine, and this is hurting me. And everyone cleared out the lobby. They pulled all the staff out. They moved the people from the waiting room out, because she started yelling too, like, I hate you, and I hate everybody here. And so then I talked to Kay, and I'm like, okay, so it feels like you hate everybody here, but you hate how no one understands how to help you and how we didn't understand your routine. And with Kay, she is an external processor, so we have to give her like guided external processing, help her name what's wrong, how it feels, and then she can put it back in her little brain to make sense of it. And I was like, this was the schedule we had to do, and this is really hard. And then she's like crying, you're like, it's so hard. And everyone did really, really great. And we talked about how much we hate changes, and then we went into the exam room. But she will just have things like this. She is a very, very high-speaking kid, but also gets really, really rigid. Okay, so now to my second example. This is my other kid, Lou, also got permission. So Lou had a hospital stay just about a year ago. This is not my medical kid, too. I was like, this is not right. Lou went from getting first IV in the ER to ending up with like multiple procedures and ending up on a PDA. So Lou is just really, really high masking, so people don't necessarily catch it. They just think that Lou's a little rude. They're brilliant, and I don't mean that like every kid's brilliant. Lou's brilliant, really articulate, and has always had a really exceptional vocabulary, especially about medicine. Lou's special interests are pharmacology and neuropsychology. Lou's interning at a pharmacy right now and just soaks up everything, and then loves studying about the brain, especially autistic brains. Really into functional MRIs and all this stuff. Whew, over my head. So Lou can keep up. Lou's really, really just, you wouldn't think Lou has problems. Till Lou had pain. So one thing that I really, really understood was how much Lou was always filtering out in order to fit in. Once Lou was in a ton of pain, none of that was happening anymore. So I had to really, really advocate to explain Lou has struggles with interoception, which is processing and understanding the input of the feelings in your body. So like, for example, Lou doesn't get that like, oh, I might be hungry. Lou's like, I'm starving, I need to eat now. Lou doesn't get the like, I'm cold, I've been shivering, I should put on a coat, it's, gosh, my limbs hurt so bad it stings, I'm overwhelmed by it. So Lou feels things on the extremes. So the other thing is that Lou has alexithymia, which is also struggles to understand or communicate or interpret what they're feeling. So Lou will be like, oh, my elbows hurt really bad. And I'll be like, remember, that's where you feel when you're feeling anxious or have like some anxiety about something coming up. But Lou interprets feelings only by like the bodily sensation and will report it instead of labeling it as emotions. So hardest part about the hospital is they're like, where's your pain on a scale, right? Or they'll use the face scale. None of that worked for Lou. So the medical team saw this like super articulate teen who's like calm and logical and assumed that Lou wasn't in that much pain. But as her mom, I could really, really tell. And Lou will go into shutdown. So then Lou gets interpreted as not cooperating. And I'll be like, Lou's autistic. And they're like, but what does Lou want? Where's the pain? So we actually had to go to a nonverbal pain scale. And I'd have to say, like, look, Lou, your legs are moving a lot. I see these things in your body. This means you're actually in pain. And then Lou would be like, and then we gave meds. But we had so much struggle keeping up with things that we ended up just doing a pain pump because it was that intense. Lou ended up with a stint. Once Lou got the stint, it turned super yellow like a Lego. And then later Lou went in to actually have surgery to have the gallbladder removed. But the big thing was that once Lou was in pain, all of the autism was like super autistic. And then needing to, like having the words of like, Lou has interoception and alexithymia and communicating that to the team, they listened. They changed. We all did the approach differently and we were able to support Lou. That's why I needed that diagnosis and I needed those words. Okay, so like I said, it's really important to take the diagnosis or the understanding of how your kid works and translate that into access. Have you seen this before, the circle of security? We use it a lot. It's about attachment. It has to do with like how kids are supposed to have the ability to kind of go away from the parent, but they want you to like support them, and then they want you to like watch what they're doing and delight in them and help them and enjoy it with them. And then they hit the point where they start to get a little overwhelmed and they want to come back to their safe base. And your job at that point is to protect them, comfort them, delight in them, and then help them organize their feelings. One big thing when I thought about this is how many parents of medically complex kids are stuck in protect me and comfort me. And we don't feel safe enough ourselves to let the kids explore because it's not a hypothetical. Stuff happened, right? We have seen what happens to our kids, and it's so hard to let them do things. The other part is play, and delighting in a child requires you to be absolutely present and in that moment, but our bodies, from being these caregivers, are stuck in hyperarousal, where we can't be present. And so then I realized like my job actually as the social worker is to kind of take the secure base for the parents so then the parents can support the kids. So it's just about being present. And I'm going to skip a bunch of things. So the really important thing is to be encouraging play with the kids, right? This is Kay, who's intellectually delayed. But do you see what she stacked up? This is how Kay plays. This is the stuff she would do. Letting her explore and do things in her own way, let me see how gorgeous and beautiful and unique she is. And I would just sit there in that moment. She doesn't want me talking through it, but she wants me there to witness it. So, really, really hard, and I have to explain this to parents all the time. You have to take the long view, okay? You have to understand that growth takes time, and it happens in the kid's own time, and that you need to be in the moment with them and just trust in the process. So there is this super gorgeous sculpture. It's a kinetic sculpture that's in Seattle. It's called Not Afraid of Falling. And what it is this kid actually does a swing over the course of a week. And to me, it reminded me about being present and letting things happen in their own time. And to delight and enjoy it, but just to understand it will happen when it happens. I have to talk with parents that have kids that have really, they have a lot of struggles with communicating what they're experiencing. And so I have to tell them to slow down. Look at your kid's heart rate. Look at how your kid's shoulders are. Look for really, really small clues to know how to engage with your child. See what they are not telling you with spoken words, but through their body, and connect with them. I have a list of resources. Another slide I had was for you all to put in your favorite resources, but the slide doesn't work. Well, no, that's just the slide of the ones that I like, but then you can put in the ones that you also like too. Yeah, you did? You put it in there? Those ones worked, but not the other ones. Okay, by Sunday, I'll be a pro. So just the part of neurodevelopment to remember is that it's multifactorial. It's biology, it's experience, it's so many things. It's not how good of a parent you are and what you've done. It's just what it is. Remember to focus on access needs instead of deficits, and that will help empower you. And remember to slow down and just delight in the moments with your child and be there with them and just go along for the journey. That's it.
Thank you, Amy. So there's one thing I've learned along this parenthood journey is that every kid is unique. None of our kids are the same. They all process things differently. They all have different needs. And slow down and come to understand how your child's brain works. When you do that and accept that, it opens up some beautiful possibilities for you. So thank you. All right, moving on, we are going to have a panel. So we will have Carly Richards, Maggie Curry, Christina Coe, and Monica Bloom join us if you'd like to come up on stage. As they're coming up, we actually need some chairs. Grab your chairs. Yeah. Bring your own chair. So one thing that we have learned along our heterotaxy journey is that it can be quite isolating. That's actually why Heterotaxy Connection was founded. I went through some very dark, lonely times and determined that that needed to change. I did not want those coming after us to have as hard of a road as we did. And so that is what we want to talk about today. That isolation, that feeling that we all very much know, and how we build off of that and find our community and our strength throughout it. All right, ladies, you ready? Yeah. Okay, so very much appreciate them. These are all heterotaxy parents. So this is something near and dear to all of our hearts. So the first question is, what has isolation looked like for you in your rare disease journey? And yes, you are all parents, so. We need this one? All three of those are all live. Come a little bit closer. Got it.
Okay. Okay, so the biggest thing for me was just nobody knowing what was going on. So I didn't find HC until after my son was born. So that initial isolation was just, I don't even have a word to explain it. You try to talk to your family members about it as much as you can, but they don't get it. They don't get that your baby is inside of you and these things are going on. So trying to process all of that as a young mom, it was really difficult. And so I really just kind of shut down during my pregnancy, which I'm sure a lot of moms do. But for me, the isolation was just, I really didn't talk a lot.
My isolation was more actual isolation, so I'm a military spouse, and so I was 3,000 miles away from home and everyone that was in my support circle. And so social media was my support circle, and it was not that robust at the time. My spouse was working in a position where he would be gone for 3 days at a time. And we didn't know our neighbors. I was literally like in this house, and my husband would show up for appointments and then he'd go back to work. And so it was just a very lonely space. And then when I made phone calls, what Carly was saying, families don't understand. Everybody wants to help fix the hurt. And in first diagnosis, I don't even know what it is yet. What the heck is this heterotaxy thing, right? I'm still trying to figure it out. We're calling other people, trying to get support, and everybody's trying to offer a solution. Oh, she doesn't have a spleen. Well, do you think they can just transplant one? And all these really ridiculous things, even stuff like when your daughter's in pain, bring her to New Mexico, we'll put her in the hot springs, because that always makes my knee feel better, right? I mean, really ridiculous things that actually wasn't helpful. It made me feel more isolated. Those meaningful things made me not want to seek their comfort because I did not have the bandwidth to explain myself, right? So there is an emotional isolation and there's a physical isolation.
I would say for me, as far as like isolation, I think it depends on the season you're in your journey. So in the beginning, definitely social media and just trying to like Google until I could Google no more to figure out like where do I find people that have even just heard of it. And I would say as the journey has progressed, I had a best friend for 20 years that just didn't get it and would put my daughter in like complicated situations. So having to choose, which was an easy choice, but obviously, just losing like people that you thought maybe got it, but just didn't. And then piggybacking off of Monica, I would also say like, for me to not feel so isolated or just alone, like social media has been a big part of it, and just finding your community or your people. Even like for my daughter, just finding others in our community that she can relate to, whether it be heterotaxy or CHD. I think it's just been super beneficial to find that support to help bring you out of that either physical, mental, or emotional isolation.
I would agree with what everyone has been saying here. We actually moved all the way across the country. So we had that, we didn't have any family on this side of the country. We left everything we knew and everyone we knew in California and came out this way. And social media actually was our lifeline. That was actually what got us to seek a second opinion. We were talking to doctors initially, and just the amount of people who had heard of heterotaxy, it was just like a blip on the radar or a blip in a book. And talking to the families on the social media, the heterotaxy families was really our lifeline. And they were such a huge support. And like was said, it's been different stages throughout the different, throughout the years. And so now we're also dealing with the fact that she now understands, oh, I am a bit different, and so I'm not necessarily seen or can do many of the things that my friends can do. And so we're kind of dealing with that and how that can be isolating, especially if going and wanting to do activities and wanting to play with all sorts of friends or even siblings.
Thank you. So I want to share a quick little story. This is something that has resonated with me over the years, but a heterotaxy parent fell in a hole. Family member says, "What hole?" A boss says, "Oh, that's a shame. You can take a day off." A doctor says, "Can you keep a diary of your experiences with that hole?" The government will say, "We will assess the size of the hole. However, it may take up to 18 months. Your local authority, sorry, we don't have enough money for a ladder. A charity, here's a form, fill it in to apply, get on the waiting list, or maybe a ladder." And then another heterotaxy parent, "I'm here. I've been in that hole. I'm coming down there with you. I know how to get out, and I won't let you do it alone." So I want to ask these ladies what that felt like when you felt that first heterotaxy parent come and say, "I've been where you are, and I'm going to help you get through this."
Okay. Yeah, you can start.
Well, I'm going to go back to Nisha on a pumpkin pie that I received because I delivered my daughter the night before Thanksgiving. And I had a beautiful pumpkin pie waiting for me, although we did not get to meet in person. That was like my first personal connection to another heterotaxy parent. That just felt really special. And it's a great memory for me to have. And I even shared with Brooklyn last night, like, maybe that's why she loves pumpkin pie so much. But then I will also say, like, that first conference in 2015 where you just really meet everybody. So not just the individual people you can connect with, like, at your center, but the families that you have grown to know over social media. And that first conference, I still have families that we connect with. And even my husband, he still talks to, like, one of the other dads. And he doesn't really talk to many people in the medical community, but he had found his person that he can go back to. So I would say just those interpersonal connections at that conference.
Way to make me cry.
Well, since you mentioned that conference was what I was going to bring up as well. My daughter was 1, and it was close enough for us to make the drive from our isolated little home on base, 3,000 miles from home. And so we made that drive. And because our only connection with these people was on social media, it was a little bit, let's put some humor in there, kind of like online dating. And there's somebody you've been talking to for a year and you finally get to meet them. Like, I was a little bit starstruck. Maggie's daughter came up with her cute little blonde curls and came up to my daughter first before coming up to us and introducing herself. And my daughter's like, okay, she was 1, so she's just like, all right. But my daughter remembers little bits of that conference. And she was 1. She's 11 now, and she still remembers aspects of that conference. She's in there playing with Brooklyn right now. The fact that we could even go to the conference because we were told that she had a 15% chance to make it to 1, and here we are at 1 and with older kids and they're playing, and that it didn't matter that these are people that lived all over the country anymore. It was like there was this little bit that we took home that it would be okay no matter where the journey ended up. Somebody gets it, right? Finally somebody gets it. That was huge.
I think I'll do both. So when I first heard heterotaxy, I Googled, which was the worst thing to do. And of course, there was only one medical journal that I found, and it was a woman in Spain who was 35. And so I had some hope, but like the only thing I could think of was, oh my gosh, this is Spain. And so just that initial meeting over social media and seeing Nisha's daughter, seeing Christian and Ethan, oh my gosh, like it brought so much hope. And especially when we were going through such a hard time when she was little, and then meeting in person. So we have my oldest is named Ethan as well, and so we always think of Allie's son as little Ethan. And so just meeting them in person, it really was like almost like an online dating thing where you're just like so excited and starstruck, like to meet in person, that it's somebody who understands just like you.
Mine, I will say, is Easton was not born prior to the first conference, so mine would be the second one. Easton was about 3, and just like the welcome when you come in, you're not really sure what to expect, because obviously we saw everything on social media and everybody's. So, I mean, I literally just told Maggie this morning or yesterday that Brooklyn's posts were the first posts that I kind of saw coming into this, and I was like, wow, there really are families out there like me. But then also at this conference today, this morning, my son was like, I don't want to go in the room. He's done this for 2 conferences now. And I went and checked in there, and him and Ethan are playing together. And I feel like this conference for Easton is now really the one where he's being able to build those bonds himself. And so this one for me is really special.
One more thing I want to say, and I think all of you can agree, there is nothing better than the feeling of walking into a room and not having to explain yourself.
Yes.
Like, you live your life on edge, and it's hidden. Like, all these kids, you look in there, you just think it's just a bunch of kids, but oh my gosh, the journey they've been on is like Lord of the Rings, and they've just come back to their village, and nobody will ever understand what they've been through, right? And it's such a relief to walk into this room, to this hotel, and like, I'm gonna be among people that get it, and that means so much. Okay, I'm done.
I love that. I love hearing how each of you have connected with each other and how it's impacted you.
So how has technology changed the way you connect with others in the rare disease space?
So I think for me, I mean, obviously we're in the age of social media and things like that. So that was my first connection to everybody with that. But then also with the social media, being able to reach people from around the globe and build those connections. So for me, my primary use of the technology right now is just the Facebook group and being able to connect with families that way and seeing families share their stories.
I found that technology, what a great day and age to live, you know? I realized that if my daughter was born 10 years prior to when she was, she may very likely not be here today. And then when we find something that works, the ability to just instantly share, which reminds me, somebody asked me if they could see a document that I have, just for an example, and I still need to send it to that person. But it's like, I can instantly help another family who I've never met, and their life can be better because of this, and vice versa, and how beautiful that is. Let's just keep taking advantage of that.
I would say as far as technology, again, like social media, and even Christina, we just had like one of the Warrior Wednesday posts. Brooklyn has this cough that sounds terrible. Like when everybody hears her cough, they think she has got this bacterial infectious illness and they don't want to come anywhere around her. but we have come to find out within the last year she has tracheobronchomalacia. And so we were able to connect because her daughter has it also. And so we were kind of joking about like what their coughs sound like. But Brooklyn was like yesterday so excited. Is she here? Because she just wants to talk to her daughter about their coughs and like just how unique and different they are. And then I would say also how technology in my daughter's journey specifically, she was one of the first in our center to have her last surgery as virtual reality. And that was not anything we found out until the day of surgery. And because of that technology, she is a bivent, which she was never supposed to be. So I would just say that gives me the ability, like our center did a piece on her in virtual reality. So I do share that a lot with other families that are like looking down the bivent path or just like, you know, asking for hope or support. It's just a way for me to share like that different experience and how far technology has come.
Yeah, I just want to piggyback on what you guys have all said. We wouldn't be here in Massachusetts hadn't it been for social media, to be honest. And I probably could say I don't think she would be around without a doubt. But social media has come, or even just technology has come so far. We have a 3D printed heart and images that we can show and talk to doctors with, and they explain to us, and it's so eye-opening, especially for visual people like me. And then on the other hand, my daughter plays with Lauren over video games, and they absolutely have the greatest time, and they relate to so much because they've been through so much and similar experiences, which is heartwarming to see.
Very much appreciate that, and it's so fun to watch the different ways in which everybody has used technology to connect with others and to better their lives. So what role do medical professionals play in helping families feel less isolated?
So I feel like medical professionals should have a very large role in that. But I feel like, and this is why we're here, and this is why we have these conferences and why things are put together. I will say that I did not get any help or anything of that sort from medical professionals for Easton when I was feeling isolated. So I feel like it's something that needs to be improved upon a lot. And again, that's why, you know, doctors are coming and speaking and creating these centers for excellence that will hopefully help these families that are coming in and with younger children and help our older children deal with things in the families moving forward.
Being a military family, we've been in front of many different medical professionals, and one of the things I've always looked for, and I found my mama bear, and I really quickly can just say, that's someone I want to work with, or that is not someone I want to work with. And one of the things is in that beginning dialogue, there's something along the lines of letting me know that I am on their team. I love it. I just boost my ego when they say, you're your daughter's expert. So I'm going to listen to you. And I'm like, yeah, you are.
Mm-hmm.
But then it takes down those barriers. And I cannot tell you how many times we've saved my daughter's life because of that motherly instinct, and a doctor listened. And also some doctors didn't listen, and we walked away and found someone that did. And doctors out there, job security, listen to your patients, and they'll stay with you. So that's where it starts, is that idea that we are all on a team. You're a part of that community that we're trying to maintain.
I would say I feel like sometimes, at least in our inexperience, I know quite a few of the families that are there, and we have a nurse, and my daughter's cardiologist has been with us since she was in my belly. And they kind of know that we have all these connections, but I think HIPAA prevents them from just being like transparent. So they give like their roundabouts a little bit, and then you kind of get your cues on who and what we're talking about. So I think as far as that goes, it makes it hard for them to maybe figure out how to, when you feel isolated, maybe connect you with more that patients that they know that they have that same diagnosis. So one ways that I have found is like I will give my cardiologist the resources that I have, and I just ask her to, she is also the interstage doctor, so she sees a lot of the CHD patients, so I just ask her to like put it out there, like let other families know that we have a community out there for them.
I can't praise Boston enough. They are absolutely amazing, the doctors that we have dealt with. They have provided so many connections and resources, from a pediatrician to family events that just took place. And I think it just kind of depends on where you go, really. Or those networking opportunities. But I do want to also add that shared responsibility or shared discussion between providers and families is so crucial. And having that open communication and understanding, it helps not only in the treatment plans, but also in the recovery. I remember having huge conversations of what would recovery look like and whether or not it meant going to a rehabilitation center or getting the chance to go home. And being fortunate enough to allow her to just go home with added supports. And she recovered so quickly.
Thank you. So we do have brochures for you if you would like to take some and give them to your providers so that they can pass them on to other families. Due to privacy practices, they cannot tell you who the other families are, but they can certainly pass on our information to them in hopes that they reach out. So let me know if you would like those, and I'm happy to order more. So we just have a couple more minutes, but I wanted to ask one last question. What advice would you give to someone newly diagnosed who feels utterly alone?
I'll make mine short, but that your feelings are valid. Anything that you're feeling, that is valid. And don't let people tell you that it's not. And it's okay to have those just stages of grief that you have. That is something that I wish somebody would have told me, that all of those things that were running through my mind, it's okay to be feeling those things.
The advice I would give is, as desperate as we are to find community, the quality of the community that you do find matters. Caregivers go through a lot. We're always focused on the patient, but if you can't take care of yourself, you can't take care of your child, right? And so find the community wherever that is, whether it's on Facebook, whether it's the old lady down the street that used to be a ICU nurse, and all that, whatever it is. Don't find grandpa so-and-so that wants you to dip your infant in the hot springs, okay? Find people that can support you in a way that makes you not feel like you have to explain yourself all the time.
I would just say, like, as much as you feel alone, you're not alone. Once you find that support, it is key to really helping you feel more secure, more empowered in my decisions, more connected to what I was researching, but then also like applying it. And just realize that there is a community out there for you.
Mine would be take each step one at a time, whether that's a couple months, couple years, couple seconds. Just take each and every single moment at a time.
Thank you, ladies. As you can see, we have a wealth of knowledge up here, but also in our communities and in our support group. And my hope is that we take forward from this the knowledge that we can make a difference, that just reaching out to that one person, finding out that that one person just is giving birth and you happen to be in town for Thanksgiving, and making that half-hour trip to make sure that they know that they're not alone. You can make a difference. So I very much appreciate you and all of you in the community that are reaching out to others to make that happen. Thank you. All right, next up, IEPs, 504s, school accommodations. We all know that as we get ready to send kids to school, it becomes very, very scary. Are they gonna meet their needs? Are they gonna see their needs? Everything from what they eat and drink to monitoring different things for them, to making sure that we work with the way their brains work. It can be challenging. School definitely amps that up. So we've invited Renee Harrell again up to talk about this and help us find some guidance on it.
Hello again. Did you miss me? It's been a while. Bear with us for 1 second while he's, hopefully we can avoid my previous technical issues. We're good? You think we're good?
Seen it?
All right. We're live. So I just wanted, obviously I was up here earlier talking about second opinions. Just a little background on me for this particular talk. Fun fact about me, I am actually still a certified educator in Massachusetts. In my previous kind of professional life, way back pre-kids, I taught English to middle school and high school levels, including students who had very significant special needs who were in Department of Youth Services custody. And then I later parlayed that into, I worked as a professional education liaison and advocate for the Department of Youth Services, kind of helping ensure I had a caseload of hundreds and hundreds of kids who received special education supports, and my job was to make sure that they received the legal protections they were entitled to under law while they were in DYS custody. So that kind of, oh, here we go. It just doesn't like me. It does not like my computer. So we'll see where we go with this, but I'll go ahead and start. So the two main protections that really apply to our heterotaxy kids when we're talking about special education law really come down to two main. 504, so we call this the tale of two laws. There's the 504 Act, which is under the Rehabilitation Act of 1973. It was the first civil rights law for people with disabilities. And it says that no qualified individual can be excluded from, denied benefits of, or discriminated in any program receiving federal funds. A few years later, that was followed up by the Americans with Disability Act that extended those protections beyond just federally funded programs into all of public life. So together, ADA and 504 require schools to remove barriers that prevent equal participation in school life to their students who have disabilities. The 504 IDA, or the Individuals with Disability Act, actually began as the Education for All Handicapped Children in 1975. It guaranteed a free and appropriate public education to students with disabilities for the very first time. It has been re-upped multiple times in different iterations, and the most current form being in 2004, which is Strength and Accountability for Evidence-Based Instruction. So under IDEA, the focus shifts from equal access to meaningful progress. Students aren't simply required to include the child, they're required to provide specialized instruction and related services necessary for measurable learning. That makes an IEP a legally binding document. The Supreme Court has clarified these standards in multiple cases that have come before them. One of the most consequential and recent was a case called Andrews F. versus Douglas County, and that changed the standard from providing a minimum benefit to a child to something called appropriate progress. And that means that your child's education under IEP has to provide more than just a minimum standard. It was called de minimis. And the exact actual definition that came out of that case was they need to receive the support necessary to make meaningful, appropriate progress in light of their individual circumstance. So both 504 and IDA guarantee a version of FAPE. They do it a little bit differently, FAPE being free and appropriate educational progress. One ensures access by removing barriers. The other, an IDEA, ensures progress through individualized instruction and accountability. So this is just a little bit of a grid that kind of breaks that out. The governing law, the eligibility standard for your 504 is a physical or mental impairment that substantially limits a major life activity. For an IDEA or IEP plan, you have to meet the criteria of 113 specific disability categories, and at the same time, you have to require specialized instruction. So the purpose of the 504, again, is to ensure equal access. Your purpose of your IEP is to ensure your meaningful educational progress. Accountability for these are found through two different departments at the U.S. Department of Ed. 504s are governed by the Office of Civil Rights. And IEPs and IDEA is through the Office of Special Education Programs, or known as OSEP. It is also co-administered and accountability through your local school district and your state, which may have slightly different standards than the federal. So, requesting an evaluation. So your child's eligibility, either under 504 or IDEA, is really going to flow directly from what we talked about for these laws. We talked about the definition of a 504 being a substantial or mental disability that impairs a major life activity. But what would that look like in practice? So for a student with heterotaxy, for example, whose health needs are affecting stamina or maybe attendance, they need to be frequently absent for appointments. Maybe they can't make it through a full school day because of fatigue or physical limitations. These then would qualify you under a 504. This is a functional test, not a medical one, meaning it really comes down to how it's impacting the child individually, not just what their medical label is. The question that's asked is this condition making it harder for the child to access the same opportunities as their peers that do not have a disability? Do they need additional support for that? IDEA is using a more specific standard. So we talked about those 13 disability categories. Heterotaxy kids will most often qualify under what's called other health impairment. And we'll go into kind of other health impairment is, the law defines that as, this is the literal definition, is limited strength, vitality, or alertness, including from a chronic or acute health problem that adversely affects educational performance. So many of the same things that would qualify your child for a 504 could transition to qualifying your child for an IEP if it is impacting them in a way that is requiring a modification to how something is taught, or it requires what's called ancillary services like occupational speech or physical therapy. Adversely affected to require individualized support does not mean that the child must be failing. It only means that their condition is affecting learning enough to require specialized support. So in simple terms, your 504 is asking, does this child need the removal of barriers simply to access learning? IDA asks, does this child need specialized or modified instruction and supports to make progress in learning? So these sound similar, but they determine which protections apply and shape everything that follows from that. So once you know which law applies, we get to our requirements and timelines. So for your 504 plan, you are usually going to request that from the principal or the 504 coordinator. You can talk to your teacher about it. They will require parental consent. There is not as much written into the law in terms of timelines. The only standard is they have to act within a quote-unquote reasonable time. The Office of Civil Rights has historically defined that to mean within 60 days, which is pretty much the same standard for IEPs, but it's just not codified that way in the law. With an IEP, you want to start with a written request to your teacher, principal, or the special education coordinator of your school. The evaluation itself has to be conducted within 60 calendar days. If eligible, the IEP or the individual plan has to be developed within 30 days of that determination of eligibility. Also, the evaluation for an IEP is required to be comprehensive. They must use a variety of measurements. They cannot rely on solely one test to make a determination. And it's also actually written in the rule that it must be culturally unbiased, meaning that they have to take into account a child's native language or other circumstances that might create a barrier to accurate testing. So, from evaluation to implementation. So if your child once has been evaluated, has been determined to qualify for either a 504 or an IEP, we'll focus on the 504 right now. That will be coordinated by your school's 504 team. Your child will likely, with heterotaxy, require what's called an individualized health plan. That will typically be co-managed by school nursing. The other accommodations in that 504 will be managed by your child's teacher, the general education staff at the school, and other staff that's there. Medical providers will often, at this point, they will be providing input on what some of those specific requirements might be for the school. So your doctor will be involved sometimes in providing this medical documentation that would be needed for that. And then that input should be integrated into your classroom accommodations that are provided for your child. The plan should be distributed to all relevant staff. And again, unlike IEPs, there isn't actually a strict definition of when your 504s should be reviewed. Best practice is typically, periodically is the standard. Best practice is at least once a year, or if something changes about your child's medical condition at the time. So IEPs, like we said, are a little bit different. They're a little bit more structured. And again, if just accommodations under a 504 is not enough, if your child's medical condition is impacting their ability to access their curriculum, that's when, this next level of support is an IEP. So this goes through and is coordinated by the special education team at your child's school. This team involves many, many more people. There, at minimum, you're going to have a special education instructor, the director of ed for that school, all the ancillary support people, your child's general education, the school nurse. It can be quite a deal, as many of you have already been through the IEP process would know. So the IEP is going to formalize how the school will deliver specialized instruction and the related services like occupational, speech, or physical therapy, so that your child can make meaningful progress. So this is going to, unlike the 504, that's providing access, the IEP is going to focus on the individualized teaching, and it's going to target specific skills. They have to be measurable, they have to be able to demonstrate progress, and they have to report that progress to you at least as often as they're reporting it for their non-disabled peers. So what might that look like for a kid with heterotaxy who doesn't just need, say, under a 504, maybe frequent bathroom breaks or access to additional hydration or a classroom on the first floor, right? Those would be some basic accommodations you might see under a 504. If that's not enough, maybe under an IEP, this might be they have small group or individualized instruction to take into account your child's earlier or extreme levels of fatigue. It could have targeted support for executive function if that's one of your child's struggles. And there will be communication between nursing staff and the special education staff to accommodate whatever your child's medical needs might be. These are adjustments in how instruction is delivered so that their learning can stay consistent despite medical variability. So every IEP must present the level of performance, annual goals, related services. When they turn 14 to 16, there will be some transition plans for preparing for life after high school. And so IEPs must be done. Goals are determined annually. Progress is documented on the same schedule frequency. And for IEPs, reevaluation must be done every 3 years. So the big takeaways here for heterotaxy, you really want to start with the impact and not the diagnosis first. The eligibility is depending upon how your child's condition is affecting their learning and participation. And from there flows where you are going to do with that. When health factors are interfering with learning itself, longer recovery periods, hospitalization, or cognitive impacts that are affecting their academic ability, they may meet the threshold for an IEP. If they really just need accommodations for medical absences or activity limitations, for example, exemptions from PE, exemptions from using stairs, access to increased food, and that is enough that they can participate with their peers and continue to make meaningful academic progress, then you're primarily looking at a 504. Our children, as I already said, will likely always qualify under other health impairment, but I did just want to make the note there are, of those 13 diagnoses, for example, autism, or specific learning disabilities that your child might have that would also qualify them under this umbrella. And there's also a category called multiple disabilities that might also be a more accurate capture for your kids. But both laws protect your child's right to be educated, and children can move between 504s and IEPs as needed. So your child might start on a 504 and then later figure out, you know, this really isn't enough. This is not working for my child. And then at that point, a request can be made for an IEP. Or it might be that your child starts on an IEP and then it really finds out, you know, they really actually are progressed to a point where they're doing well enough that actually this is no longer a level of support that they need, and that actually a 504 is going to be just fine. I do think for almost all of our children who have ongoing medical needs that would require any type of specific support from the school, a 504 or at the very least, that individual health plan will be something that you are going to want to get for your child and communicate regularly with your school for. So these are just a couple of really good resources that can be used at any time to explore more on this topic. Rights law has been around for a very, very long time, and they always keep up to date on the most recent advances in special education law. The Parent Center Hub gives fact sheets. I want to point to parents training information centers are required by federal law in every state. So you can go to the Parent Center Hub and find your state-specific one, and they can give guidance on what is going on in your local and state as it relates specifically to special education law. And the Council of Parent Attorneys and Advocates provide resources if you're struggling with your school district, if you're having a really hard time and feel like you're not being heard. They provide resources, training, and also legal referrals if it got to that point for you. So that is all I have. I'm happy there's a few minutes. If anybody had any questions, just kind of leaving the floor open if anybody had. Oh, I see a hand over there. I think you have to come up to the mic. The long sprint upward. Really make you commit to this question, right?
Okay, so Lauren just got her 504, and I heard through the grapevine that she can carry that document all the way to college if she decides to go to college. Is this true?
Very good question, and yes and no. So 504s, because they apply to any place that gets federal funding, those accommodations will be reevaluated at the college level, and most likely, yes. IEPs, I do need to make a very specific note. Your rights, your child's right under IEP law ends at their high school graduation or age 22. The day of their 22nd birthday, they age out of eligibility. If you have a child who is graduating on time and is going to college, that means they've graduated, and the IDEA does not apply to college. So it can kind of feel like a little bit of a rude shock. That's why it's really beneficial when your child turns 14 or 16, depending on your state, and there starts being transition, to really start talking about what kind of documentation you're going to need to put together, because you're going to deal with your Office of Disabilities in college, and they will not get an IEP plan. And all of those accommodations will have to be individually negotiated with the college at hand. But it is important to note that they are still carry the same requirements under the American with Disability Acts and the Rehabilitation Act to remove access to barriers to equal access for any person who has a disability on campus. Any other questions? If there are, feel free to find me. I'm hanging around conference, and obviously these are all great resources for you if the questions come at another time. Thank you so much.
Thank you, Renee. Couple quick things to keep in mind. It's okay to use handy dandy AI to go in and say what accommodations might be appropriate for this condition. Last year I went into my high school with my son. We had pulled up all of these accommodations, pages worth of accommodations for ADHD. We highlighted the ones that we felt were most applicable, took them in, showed them to the principal, who was like, I hadn't even thought about some of these. And I'm like, I would never have known to ask for some of those, and that it was available. So this is an instance where AI and Google can be very, very, very helpful. Other thing to keep in mind, your child may be on a 504
or an IEP. They can go back and forth depending on their needs. However, it is still best to meet with those teachers and make sure they are fully aware of what those accommodations are. And make sure your child knows what their accommodations are. They need to be able to speak up for themselves. My daughter, when she was in kindergarten, had spinal surgery. Wasn't supposed to be carrying a backpack, wasn't supposed to be at the back of a line in case somebody accidentally bumped her. Had a substitute teacher who didn't know any of this, and she put them in their place pretty darn quick when they put her at the back of a line and tried to make her carry something. So make sure your kids know what their accommodations are. They need to learn to advocate for themselves from a very young age. And to start that process, educating them. Give them the knowledge that they need in order to advocate for themselves. So, thank you, everyone. We are going to take a break for lunch now. So it is in the Washington Ballroom where breakfast was this morning. We will return at 1 o'clock.